Hmm, Apologies, I was speaking while muted. So, good morning and good afternoon, everyone, again. So, welcome to the second day of the lecture series on pediatrics pathology. Today, Dr. Diana Thomas and Dr. Chain will be with us to present on at least three different topics. First on will be Dr. Chain. Dr. Sonja she'll be presenting on HSD. And as I have introduced Dr. Sonja yesterday, she's a clinical associate professor of pathology, and she's the head of the autopsy unit in the anatomic pediatric fellowship program. Overall, she's the head of the pathology department at Ohio State University at the Nationwide Children's Hospital. So I welcome Dr. Chain. Also with us are Dr. Diana Thomas, who is also a clinical assistant professor of pathology. She's also a member of Department of Pathology there at Ohio State University. Dr. Rahel, which is one of the panelists and one of the coordinators of this session, head of Department of Arts University Pathology Department. Everyone, and including our participants, welcome to this today's session of pediatric pathology. So I think we can begin our session for today. Dr. Chain, it's all yours. Thank you very much.
Thank you so much. And thank you everyone for starting to be with me here today. I hope that this will be quick and you'll have enough time in the end for discussion. So my talk, as Akilu mentioned, is the pursuit of ganglion cells and Hirschsprung disease. And as we all know, this can be a lot of fun to do when you have a case. So the objectives, just to review the definition, history, and classification of Hirschsprung disease, the role of our job while we take care of patients who have Hirschsprung disease, and review adjunct testing in the diagnosis. And I also have a little outline, which looks very similar to all my other lectures, because I like to include how we got there, what are we doing, how genetics is associated, how we make the diagnosis, how these patients are treated, and of course, if there are any advances or new discoveries. Hirschsprung disease typically occurs in the US in about 1 in 5,000 live births. I think the number globally is probably something like 1 in 7,000 live births. And there's functional intestinal obstruction in the neonatal period. It's the most common clinical symptom is, of course, delayed passage of meconium within the first 24 hours of life. And that's present in up to about 90% of patients diagnosed with Hirschsprung disease. Of course, the initial presentation is a neonate with abdominal distension and forceful passage of gas. You can see this little baby has a very, very distended abdomen. And then the only time that they will actually pass gas and meconium is once you've done a digital rectal examination. Serious complications like Hirschsprung-associated enterocolitis does occur in up to 25% of these babies. And older children can present with chronic, severe, and unexplained constipation. They sort of get away from people's ability to diagnose as they get older, because they probably have a short segment, and so they kind of compensate for having a non-functional area of colon. So what's the primary pathology? It's aganglionosis of the enteric nerve plexus, and we'll talk a lot more about that in a second. And that, of course, results in tonic contraction of the affected segment, intestinal obstruction, and distension of the proximal bowel. So here you can see this anatomically laid out specimen. Here is the terminal ileum and the ascending, transverse, descending. You should have sigmoid and rectum. Colon, and you can see the aganglionic segment looks quite atonic and small, and the proximal bowel is quite dilated. Now, this is the bowel of a neonate, so it's quite small. It looks quite small, but this 5 centimeter dilatation is absolutely abnormal in a little baby. So you can see what can definitely happen. In this particular case is a case of total colonic aganglionosis, wherein there were no not total colonic. This is a case of short segment, because there was no ganglion cells up to about here, and then we found ganglion cells further up. And you can see on imaging in the barium enema that there's a transition zone. You can actually appreciate the filling of that large dilated proximal bowel, and then subsequent to that, very little filling happening in the aganglionic or atonic segment. And of course, the pathologic diagnosis, unlike the rest of pathology, it's dependent on the identification of the absence of something, meaning the absence of ganglion cells at the plexuses that either are submucosal or myenteric in the bowel wall. One other bonus finding that you can have, it doesn't mean that you'll always have it, is the presence of large nerves that are greater than 40 microns. And this is heavily dependent on age, and we'll talk a little bit about that later. And then increase acetylcholinesterase activity in the lamina propria or decrease calretinine, another thing that sometimes we use as an adjunct along with our H&E. So let's go back to the history. Pre-Hirschsprung, before we knew this disease as Hirschsprung, this was actually described in India in 2000 BC by Sushruta in Ayurvedic tomes. Between his description and the findings of Hirschsprung, there were only 20 cases that were documented with a similar description before Hirschsprung actually created a formal description. And in 1892, there was a gentleman known as the human windbag or the balloon man. At 29 years of age, he has had a photograph here, and you can actually see his megacolon, which is quite long and distended, at 25 feet long, and you can see it in the Mutter Museum in Philadelphia if you're ever interested. I've seen it before. It is quite impressive. And so Dr. Harald Hirschsprung is a Danish pediatrician who first described the Hirschsprung disease in the literature that we sort of name. He has the name to that fame. And in 1886, he provided the description of the first two children who had intestinal obstruction. And he called it congenital megacolon. And then people started calling it Hirschsprung's disease quite shortly after that. So how do we get Hirschsprung disease? It can either be familial or sporadic. The majority of cases, of course, are sporadic in about 80% of patients. And familial cases do have low penetrance. The transmission is influenced by gender, so males are far more affected than females. It may be an isolated trait in about 70% of those patients who are familially driven. And it can also be associated with chromosomal abnormalities, such as trisomy 21 in about 10% of those cases. And what kind of forms of Hirschsprung disease? Well, clinically, we have ultra short, which occurs just below the rectosigmoid junction. I don't have that pictured here. We have short segment, which occurs up to the sigmoid. We have long segment, which occurs up to, somewhere around here, transverse colon, and then we have total colonic ganglionosis, which includes the entire colon, which is like the image that I had showed you before. And so how does this begin? Where does the embryology start from, and what's the normal innervation? Well, we have three sets of cells that really help to develop this gut in the embryo, and they are the vagal neural crest cells, the anterior trunk neural crest cells, and the sacral neural crest cells. And they all work really hard to innervate this entire tube once it has been developed. The signaling pathways are very complex, and as you can see, I'm just highlighting here the number of genes that are involved in the development of your colon, and therefore, of course, if there are issues with that gene, either as a germline or sporadically, then you will end up with Hirschsprung disease. So how does that function? As I mentioned before, vagal neural crest cells and sacral neural crest cells begin to inhabit that tube, and as they inhabit the tube, they result in the development of neurons and then glial cells. And neurons develop first, followed by the wave of glial cells. And you can see here another image. I really like this image because it kind of helps to explain the reasons why Hirschsprung develops the way it does. So as undifferentiated neural crest cells move along, in the back behind them are the developing neurons and their neurites. And this is what eventually, this neuronal differentiation is what eventually will remain in your gut and what helps to provide tonicity. But in that wave front, as it develops, you can imagine if something halted this development, you would have these neural crest cells that don't really conduct or don't really have any tonicity in this area at the front of the wavefront. And that's the area that you would expect Hirschsprung to occur in, because you don't have much in the way of neurites and developed neurons, and therefore no tonicity in this particular area. So here's just another image that demonstrates the exact same thing. If you imagine these dots as being areas where you have normal ganglionation and normal neural development, then as you progress to an area where you do not have ganglion cells, there is an area of distribution that can be very, very irregular, known as the transition zone. And that essentially is what I have at the top here, which is failure of colonization by those neural crest cells. If you don't have neural crest cells, you can't develop neurites, you can't develop neurons, you can't develop ganglion cells. And therefore, you develop an aganglionic segment. Many times we are tasked with the obligation to identify where the transition zone is, and we'll talk a little bit about how we identify it in a bit. So I wanted to make sure to show you that there's a lot of genetic heterogeneity and associations with Hirschsprung. I just put this table in front of you for you to see how many genes there are that are involved in the development of Hirschsprung disease. It's multigenic. So therefore, when you're trying to replicate it in animal models, it is very challenging because there are so many alterations that can result in Hirschsprung disease that it is very challenging to choose just one. Some people have, and they use certain mouse models just to identify this one gene, particularly the RET and GDNF, but it is kind of difficult sometimes to create a mouse model that replicates exactly what happens in human beings in order to understand the process. And here's another, just another image that shows you all the players. So this is RET and GDNF. These are membrane molecules that are responsible for interactions with neurites. And unfortunately, when this does not work, or when you have some alteration in these genes, therefore you have down regulation or underexpression most times of the protein, and therefore something breaks down and you will end up with Hirschsprung disease. And I'm just going to highlight some of the different players. So RET and FOX2B and SOX10. FOX2B we talked about yesterday in the context of neuroblastoma as well. So as I mentioned, there are lots of genetic alterations, and I showed you just a couple of the chromosomes. There are lots of syndromes: Waardenburg, Shaw, Movat, Wilson, Goldberg, Spritzen, and then congenital hypoventilation syndrome, which is associated with the FOX2B mutation. These patients not only have Hirschsprung disease, but they may have neuroblastoma. And then, of course, there's an association with Down syndrome in anywhere from 2 to 15% of patients. Other associations that you may see is intestinal atresia. So unfortunately, the patient may have Hirschsprung in one spot, and then they may develop intestinal atresia elsewhere. And of course, that can happen because ganglion cells are present in the gut proximal to the site of atresia, and then they may be absent distally or only present at the blind-ended atresia margin. And that, of course, could be due to a vascular event during gestation that could interrupt neural crest cell migration. You see how easy those little cells are happily mingling and trying to make their way to the wavefront to innervate the entire length of that colon. So any process that could prevent them from and that's usually vascular or ischemic event that could prevent them from migrating will certainly do so, and you will end up with intestinal atresia and loss of ganglion cells. So that's why in those specimens, we also look for ganglion cells to ensure that the patient has normal ganglionation. And similarly, in anal atresia, which can be seen in patients with trisomy 21, you may have a similar process occurring. So let's talk about the star of the show, which is the ganglion cell. Morphologically, how do they look? They're polygonal, vacuolated, amphoteric to eosinophilic cytoplasm, and they measure about 15 to 40 microns in diameter. They can be oval, or they can have oval or round and sometimes reticular-looking nuclei with a prominent nucleolus. They must have a prominent nucleolus, and that nucleus usually measures 10 to 15 microns in diameter. And then the ganglion contains numerous Schwann cells and variable numbers of ganglion cells together. So you can see an image of that. And then where are they distributed? Well, of course, ganglion cells are distributed in the submucosal plexus, and those are usually smaller in size, and they may be near the inner aspect of the circular muscle. So you can see here the circular muscle, or they may be immediately deep to the muscularis mucosa. So somewhere in this location here where we have submucosa. And then the ganglion cells in the myenteric plexus or the muscularis propria will, of course, be in larger groups, and they're usually situated between or nested between the circular and the longitudinal muscle that you see here in this image. So how do we establish the diagnosis of Hirschsprung disease? Well, typically, most people do a biopsy in order to identify an area that might not be innervated. And some people do punch biopsy with anoscopy. Folks do punch biopsy. This is just an example of what some folks have done with a test tube and a side hole and using laryngeal biopsy forceps if you're doing it right there in the rectum. But one thing I have to bring to the attention of everyone is that you have to understand the anatomy in order to determine where's the best place to biopsy, because we do, as humans, have a physiologic hypoganglionic zone. And that area is the segment of the anorectal region between the anal valve line and the point where you first start seeing ganglion cells. So one of the first studies to examine this area was done in 1968 on autopsy patients. And they noted in patients, and you can see here premature infants, in infants from 1 to 28 days, babies 1 month to 1 year, and children 1 to 15 years of age. And I'll just show you in the first centimeter, they looked at ganglion cells, and how many cells per ganglion, but I will just bring your attention to the ganglion cells. And in the first centimeter, you can see that in the myenteric plexus overall, there were far more ganglion cells in general compared to the submucous plexus in all 3 categories of all 4 categories of patient. If you move to the second centimeter, you will see that the myenteric plexus once again has the most number of ganglion cells, but also you'll start seeing more numbers in terms of presence in the submucous plexus. So finally, when you get to the 3rd centimeter, it definitely has a vast improvement, and you start seeing much more submucosal as well as myenteric plexus ganglion cells. So that's one piece of information. So we think about that when the biopsy is performed. And then the other thing that they notice in this physiologic hypoganglionic zone is that hypertrophic nerves are frequently noted in that zone. The nerve growth precedes the arrival of ganglion cells, and large nerves will be seen in areas not invaded by the caudal migration of those cells, both in normal and abnormal rectums and anal canals. So in other words, if you biopsy the 1st or 2nd centimeter of the anorectal canal, or basically anal canal, you may not see very many ganglion cells, and you may also see very large hypertrophic nerves that are coming from an external location. And so here is the pictorial example of those groups of individuals. But where do you really want to take that biopsy? Based on what I just told you, at least 2 centimeters above the pectinate or dentate line. Here's the anal canal. Here is the anal verge. So you want to make sure that the biopsy itself that you receive, your diagnostic biopsy, should be at least 2 centimeters above that pectinate line, because you have innervation coming from an external source, meaning not those sacral sacral neural crest cells are not innervating this area. So you want to make sure that you're getting this area up here so that you can truly identify whether or not they're ganglion cells, one, and because we use those hypertrophic nerves sometimes to make a diagnosis or to help us with our diagnosis, we want to make sure that we're not seeing hypertrophic nerves up here. If we see hypertrophic nerves down here, that might be all within the realm of normal. If we see no ganglia down here, that might also be within the realm of normal. So this is the reason for the importance, or stressing the importance, especially to your surgeons if they don't already do it, that they should be taking a biopsy from at least 2 centimeters above the pectinate line. So what kind of biopsies do people take? The first up here is the rectal suction biopsy. I'll tell you more about that. You can take a seromuscular biopsy of the external aspect of the or the wall of the gut. And then you can also have a full thickness biopsy, which clearly has mucosa and submucosa all the way out to the muscularis propria and whatever adventitia or serosa is present. So let's talk about the rectal suction biopsy. Rectal suction biopsy was described first in 1965. Actually, they used patients with ulcerative colitis. But what did they do? They biopsied 2 to 3 levels in the rectum at 50 to 100 sections each. You can see here, this is an old black and white picture, but we typically do the very same thing, lay them out and cut them multiple times. And then ganglion cells were easily identified in any of these sections, and they only found an absence of ganglion cells in 3 patients with Hirschsprung disease. So here's a much more modern image of what we would typically see in H&E for a rectal suction biopsy, where you can see mucosa, some of the muscularis propria, the muscularis mucosa, and then some of the submucosa. And I'll move to another slide, which basically describes what are our minimum requirements for rectal suction biopsy. So it should be a 3 millimeter diameter fragment of tissue and at least 1/3 submucosa. Some folks say 50-50 submucosa to mucosa ratio, and that's perfectly fine as well. The reason being, while you want to evaluate the mucosa, the submucosa is where it's at because that's what you're looking for to find those ganglion cells. So if you don't have adequate submucosa, you cannot give an adequate diagnosis or an optimal diagnosis. And of course, you have to orient these properly and section them adequately. I have 50 to 75 sections that came from Dr. Raj Kapoor, who is a well-known pathologist who does a lot of Hirschsprung disease, but typically many labs do all the way out to 100 sections. And that's perfectly fine because, ganglion cells can be anywhere between 5 and 500 microns apart, and you need to make sure that you section appropriately. But you also need to make sure that it is properly oriented. I'm sure if you've done Hirschsprung biopsies before, if it is poorly oriented, you're looking at mucosa for half of the slides until you start seeing submucosa if it's not really oriented well. And then, of course, there are reported rates of inadequate biopsy in about 10 to 20% of the biopsies that are performed as a rectal suction. And many times that's in the neonates. We do experience that here as well. And sometimes we have to ask them to go back or ask the surgeon to do a deeper, better biopsy so that we can actually give a diagnosis. Next up is the seromuscular biopsy. And you can see that here is the surgeon endoscopically doing that seromuscular biopsy. It's a minimum of 1 centimeter in length and a depth of 3 to 5 millimeters and should include the longitudinal and most of the circular layers of the muscularis propria. Remember, this is usually being done in a neonate, so it's not a huge specimen. It's very, very tiny and usually employed at the time of frozen section. So the advantages, of course, with a well-oriented biopsy, 10 sections are generally sufficient to confirm or exclude a ganglionosis. But of course, like I mentioned when I showed you the transition zone, if you biopsy an area that has ganglion cells and on the, lateral border, away from it, there's a transition zone and there's no ganglion cells, well, you might not be able to tell that based on this biopsy. And of course, it can be difficult to distinguish a seromuscular biopsy of a euganglionic from hypoganglionic transition zone, like I was saying. But typically, the surgeons correct this by resecting about 3 centimeters or more above the biopsy site. I have seen surgeons go 5 centimeters above the biopsy site to make sure that they're not in a transition zone. And finally, the full thickness biopsy includes mucosa, submucosa, muscularis, and adventitia. It's usually performed as leveling biopsies at the time of frozen section, but can also be done endoscopically. So where does the frozen come in? We evaluate for Hirschsprung disease during the time of the frozen section. And of course, the results can have immediate effect on the surgical management of the patients. And so reliability and error prevention are really important for the surgeon as well as the pathologist. So some of the pitfalls of ganglion cell identification and frozen section, well, sometimes on the frozen sections, you may not see them. They're present on the permanent sections, but absent in the frozens. And this is, of course, why you must do multiple levels. We typically do 4 or 5 levels of these biopsies once we get them at frozen section in order to try to maximize what we can see. at the time of frozen section. And of course, immature ganglion cells, when you have these little babies, I can tell you that these things turned out to be ganglion cells, but it's really hard to tell what they are here. In this frozen section, they're small in size. They have a very little cytoplasm, maybe even mistaken for things like plasma cells. Some of these in here could very well be ganglion cells, but there's a lot of inflammation as well as admix, and it makes it very, very challenging, particularly in the tiny babies. So the general rule is to better to make a false negative error and say no ganglion cells identified or no definitive ganglion cells identified. I've certainly done that before when you're uncertain, and then it will prompt them to do another biopsy, perhaps at a higher level, so that you might be able to see better ganglion cells. So interpretation of the permanent sections, what should we do? We should comment on the type of biopsy. If it's seromuscular, a rectal suction biopsy, comment on the adequacy, particularly for the rectal suction biopsy of at least 50% mucosa to submucosa. Comment on the presence or absence of ganglion cells, whether they're single cells or in clusters, and comment on the presence of hypertrophied nerves, which is greater than 40 microns. And of course, you should measure the nerve to get the diameter, but with a caveat. So it's really important for us to know that submucosal nerve hypertrophy is a feature of the transition zone in Hirschsprung disease. And in general, submucosal nerves greater than 40 microns can be seen in post-pull-through specimens for patients who have Hirschsprung disease. However, these two studies above here, I just put the titles of the studies in here, both demonstrate that while you may have nerves that are greater than 40 microns in patients who have pull-throughs that have Hirschsprung disease, you may also find such caliber nerves in the normal distal rectum of children over 12 months of age. As a result, when you have biopsies coming from children over 12 months of age and you have nerves that are greater than 40 microns, you can no longer be sure that this is not normal within that age group. And so these are usually found in more proximal colon at older ages as well. And so, of course, when you get your sigmoid colon biopsy and whatnot, and you see nerves that are greater than 40 microns, you cannot be sure that in that age group greater than 12 months of age, that you are not dealing with something that can be physiologically normal. So how do we treat Hirschsprung? Because that's also really important. Traditionally, there has been the two-stage approach that you establish a diagnosis by biopsy, you do a leveling colostomy to decompress the bowel, and then the decision for that colostomy is determined by visual inspection and looking for transition zone between the aganglionic and the ganglionated bowel. And then, of course, the presence of ganglion cells on the proximal side of the transition zone is confirmed by frozen section. And then those patients, if they were doing the two-stage approach, would then reanastomose and excise the aganglionic segment as the second surgery. And that might be many months or as much as a year later. There is a one-stage approach, which I feel like most of the centers nowadays do, unless the patient has other concurrent comorbidities. And this has been around since the 80s. It's essentially excision and reanastomosis as the initial and only surgery. But of course, it relies heavily on the diagnostic accuracy of the initial biopsy specimen at the time of frozen section. So the surgeon essentially depends on you to determine whether or not he's going to make do a pull-through at that level, wherever you have given him the site of ganglionated bowel. So who gets a one-stage versus a two-stage? Typically, the one-stage procedure is neonates who aren't very ill, but the multi-stage procedure usually occurs in patients who are severely ill. They have enterocolitis, long segment Hirschsprung, or total colonic aganglionosis. In general, when you have multi-stage procedures, you have worse outcomes. They have more readmissions, more surgical site infections, more small bowel obstructions, more episodes of enterocolitis, and many times they will have additional pull-through procedures, so redo pull-through procedures. I just put this up here because I think that it's really important for us to understand the surgical procedures that occur. So there's the Swenson procedure wherein all of the aganglionic bowel is removed, and essentially this pink part is the ganglionic new bowel and brought down to the level of the anorectal transition zone above the internal and external sphincters. And then there's the SOAF, which essentially retains some of the the aganglionic bowel, though it is kept sort of on the outside and maybe adheres to the outside of this ganglionated bowel. And then there's the duhamel, wherein your ganglionated bowel is brought in and attached in the posterior aspect of the aganglionic segment. And as a result, if you do get this redo pull-through, you will find that there are portions of the pull-through that have no ganglion cells. So this is just important for us to understand when we get those specimens, what we are getting. And I wanted to touch a little bit on the histochemistry and immunohistochemistry in Hirschsprung. So the three main stains that one can use is acetylcholinesterase, which I would say historical use only. I use it only in fellowship, and I don't think I've seen any other places that use it. Calretinine and choline transporter. And so the acetylcholinesterase, essentially, you can see it here. If you have a ganglionic segment, there's no staining. You can use it at frozen section because it's an enzymatic stain, because normal nerves do not stain for acetylcholinesterase. However, if you have an aganglionic segment, then these fibers become very, very thick and ropey, and you can readily identify them once they're stained. And so those coarse cholinergic fibers are what we expect in the muscularis mucosa and the lamina propria. And what are the disadvantages? Of course, there can be false negatives. They are very challenging to interpret. I've seen that with my own eyes. There's increased staining with age. The cases with total colonic aganglionosis have aberrant staining. And of course, there's increased staining in the ganglionated portion of patients with Hirschsprung disease. So it's really a challenge to use this histochemistry, and I would advise against it unless you have no alternative. Next is the calretinine stain, and aganglionosis here is associated with complete absence of calretinine immunoreactive mucosal nerve. So you can see up here, this is normal. Here is your here are your glands in your mucosa, and you can see these nice long calretinine positive neurites or nerve fibers going up. And you can also see ganglion cells being highlighted by it, although this is not the purpose for which calretinine is performed. In the patient who has Hirschsprung disease, you can really appreciate that there are really no neurites. The only thing that usually stains in these patients with calretinine are sometimes mast cells, which are not pictured in this image. And then what are the disadvantages of calretinine? Well, it can be misinterpreted due to technical failure. Unfortunately, when you do a lot of free storing of these specimens, some of these commercial antibodies may lose their immunoreactivity, so it might be a challenge to reproduce or to stain them well after using a frozen section biopsy. And then spurious mucosal immunoreactivity can also be seen in Hirschsprung patients, and that can lead to a false negative diagnosis. And usually that's occurring in the proximal aganglionic segment, just near to the transition zone. So I'll show you here. These are just examples in the literature. I've never seen this myself, but calretinine positivity, you can see in the large nerve fibers. Here you see the 2 case reports. And then some folks have even reported calretinine positivity in the lamina propria. And again, this can happen in the transition zone because, as I showed you, those neurites send out those neurons send out their little neurites, and that might be at the head of the wave front, but your ganglion cells would not have developed, or your glial cells would not have developed in that area. And then the last stain that I wanted to share is choline transporter. It's the new kid on the block. A lot of people had a lot of faith that this would be very, very helpful. And of course, it can be used on frozen section tissue and FFPE. It has a very similar staining pattern to acetylcholinesterase. So here on top is the acetylcholinesterase in the aganglionic segment. And as I mentioned before, you don't have any staining in the ganglionic segment. And so when you use choline transporter, it has exact same staining. So the presence of this coarse irregular staining would be useful, and you can see it has a good positive predictive value and negative predictive value. However, I will say that in practice, it's very hard to optimize the stain, and I have gone to Raj Kapoor himself to try to get all the details of how to get it to work and have been unsuccessful in 2 different laboratories. And here you can see this is a false negative calretinine, probably in a transition zone area. Here you can see mast cells staining with calretinine. And here is the choline transporter, which actually has immunoreactive nerves. So this is a patient who has Hirschsprung disease. You really shouldn't be seeing, in an ideal world, you shouldn't be seeing calretinin positivity, but because it is a transition zone, you start seeing these little neurites in here. But this is considered false positive because you're seeing calretinin positivity in an area where you know that it's a transition zone and really should not have ganglionation. So in our practice, I'm just mentioning, we typically do one-step procedures. We utilize H&E and DiffQuick on frozen sections, and I'll show you the DiffQuick in a second. We use H&E and calretinin on permanent sections, and we also serve as a center for redo procedures or failed prior procedures. So this is the reason why I shared, what histology we should expect in the procedure types. And as I mentioned, it's really difficult to replicate the immunohistochemistry with choline transporter, so we do not use it at all. So here's a DiffQuick at seromuscular biopsy frozen section. You can see that this is a frozen section with a lot of artifact. I will tell you that these are the 2 layers of muscle, and here is the slip of where you should see ganglion cells, and easy to identify. The cytoplasm stains in blue, and it usually is very helpful if the technical skill of the person that is doing it is good. Here's another one where you can see mucosa here, and in the submucosa, readily identifiable ganglion cells. So this is what we use at frozen section. We do an H&E and a DiffQuick, and that usually helps us resolve whether they are ganglion cells or not. So I have a couple illustrative cases in the last 15 minutes that I'm going to go through. So here, this one is actually a little bit interactive, and I don't know if folks can say anything about this, but I wanted you to determine the adequacy of each biopsy fragment based on what I have spoken about. Is fragment A adequate? Does it look adequate? You can type into the chat and say adequate or not adequate for A. And then we look at fragment B. Does that look adequate or not adequate? And then we look at fragment C. Does that look adequate or not adequate? I'll give you a few moments to think about it anyways, and then I will reveal the answers to you. So fragment A, of course, is definitely adequate. You can see 50% mucosa and 50% submucosa. Fragment B is definitely not adequate. Although you can see a little bit of mucosa and submucosa, it's really not a 50-50 at least, and it's almost gone. So many times you have to do levels on this particular specimen in order to identify what's going on here. And fragment C is also not adequate. Fragment C is a fragment of squamous anal mucosa. So this would never be, you would never be able to use this for diagnosis of Hirschsprung because, as I mentioned, the innervation is very different from the rest of the gut. And so this is just the answer. The first case I want to share is I only have 2 cases, so don't worry. It's a 2-day-old female with failure to pass meconium. Findings were, as you can see here, very small colon with minimal contrast refluxing into a very narrow caliber distal ileum. And here are the frozen sections. You can see a full thickness biopsy here, and there are no ganglion cells present. I only showed my enteric plexus, but you can see a little of submucosa here, wherein there are no ganglion cells present. And then in the distal jejunum, they did a full thickness biopsy, and you can see the mucosa, submucosa, and muscularis. And here in the muscularis, again, now you can really appreciate ganglion cells. On the permanent sections, we did a calretinin stain, and you can see the calretinin stain even at low power. You can't even appreciate anything in the muscularis. And here, really easy to see that there are no calretinin staining here. In the distal jejunum, however, you can see really nice, at least low power brown calretinin stain here, and then meaning that there are probably ganglion cells inside of there, which you saw already on H&E. And then, of course, in our lamina propria, I can show you here these lovely little nerve twigs, and on higher magnification, if you were just wondering, they really truly are ganglion cells. And so this case would have been signed out as, having small intestinal tissue with no ganglion cells present on H&E in the ileum, and in the distal jejunum, of course, they're present. And I just want to mention that calretin positive nerve twigs were present in the small intestinal sections, but not in the sigmoid colon. So there were ileum sections, there were colon sections. I didn't show the colon section because it is exactly as the ileum. And at that time, there were no hypertrophic submucosal nerves. And this is one thing that you can see in this type of case. So no ganglion cells in the sigmoid colon, no ganglion cells in the terminal ileum, but ganglion cells in the distal jejunum. So this patient underwent what I'll show you next. So found to have microcolon, biopsy evidence of ganglion cells only in ileum and jejunum. And then they did a leveling jejunostomy and a mucus fistula at the time to pause. These are total colonic ganglion. This patient obviously has a diagnosis of total colonic ganglionosis, and this, of course, may lack hypertrophic nerves. The patient subsequently developed intestinal failure and went on TPN and then had a subsequent ileoanal anastomosis as they allowed the bowel to grow. And so here you can see the angiogynostomy and a mucus fistula that happened at the time of surgery. I'm seeing someone writing in the chat. Please say something about immature ganglion cells. If we find them only, is it a ganglionic segment? So it depends. I will address that, but essentially it depends on what you have. If you have a full thickness biopsy and you see immature ganglion cells involving at least 7/8 of the circumference of that donut, then I would say yes, it's a ganglionic segment. If, however, you have a biopsy, even if it is a full thickness biopsy, you can see that there's ganglion cells present here, but you will not be able to tell if it involves the entire circumference. And let me move back to the case. So the next case is a 13-day-old male with failure to pass meconium at 48 hours of life. Patient was found to have a very small rectum. You can barely see anything going down here into the rectum. A dilated redundant sigmoid colon loop. You can see this huge, all of these loops here, dilated bowel. And then the transition zone in the distal sigmoid colon, of course, suspicious for Hirschsprung disease. So here's the frozen section. The proximal rectum really looks bland and higher magnification. You can see no ganglion cells. In the distal sigmoid ceromuscular biopsy, again, now we start to see our friends, the ganglion cells. And in the mid sigmoid, they did a full thickness biopsy. And you can see ganglion cells here again, nicely. So this one, kind of easy. The first biopsy of the proximal rectum, no ganglion cells. Second one, myenteric ganglion cells present because this was a ceromuscular biopsy. And the third one, submucosal and myenteric ganglion cells present because this is a full thickness biopsy and we didn't see any nerve hypertrophy in that full thickness biopsy. So then the patient underwent a pull through, and here's the procedure. We had leveling biopsies. They made a mucosal incision about 0.5 centimeters above the dentate line. The silk sutures were placed along the mucosal edge and dissected for about 2 centimeters. The muscle was divided and the dissection was carried proximally until the rectal, on the rectal wall until the site of the normal biopsy was reached. And then the colon was divided and anastomosis between the ileal, well, in this case, it was colonic junction and the anal canal was performed. And here's the pull-through specimen. You can see that area of mucosal tethering with lots of those sutures and then multiple biopsies that were performed that I showed to you before. And here's your distal end and your proximal end. And upon opening, you can also see the distal end. The caliber looks slightly wider. Sorry, this is the proximal end. The caliber looks slightly wider, the distal end with all of the sutures on the end. So how do we submit that pull-through specimen? Typically, we do an en-face frozen section of the proximal margin. And you can see here, there are 2 ways to do it. If it's small enough, you can put it straight on its own, and that's a whole donut. If it's much larger or very, very big, you cut it into strips and you set it aside and you align the segments. And you can see that here, either donut or line sections. And then when you're grossing it, you can do proximal end, distal end, and a longitudinal strip. And this strip will then be cut into sections to put in your cassettes. Or you can do a proximal end, the distal end, and multiple complete sections through the in a transverse manner through the entire colon. We typically use this format. It's much easier and faster. And if we have questions, we always put a second longitudinal strip in if there's a concern. So here you can see the proximal rectum ceromuscular biopsy, and you can see that there's a very large intramyenteric nerve, but no ganglion cells. And then the distal sigmoid ceromuscular biopsy, easy to see those ganglion cells. And then here is the full thickness biopsy and easy to see the ganglion cells. And then just showing you at the distal end of the pull through this aganglionic myenteric plexus that is present. And then the proximal end, you can really appreciate in the submucosa, nice ganglion cells. And then in the myenteric plexus, nice ganglion cells with a prominent nucleolus. So overall, this patient was found to have a dilated sigmoid colon with transition zone, no ganglion cells in the proximal rectum and rectosigmoid junction. Patient had a pull-through as we went through, and then was diagnosed with a short segment Hirschsprung disease. And at genetic testing, was also found to have trisomy 21. So when we analyze these Hirschsprung disease resections, we're trying to confirm the diagnosis, map that transition zone, and assess the integrity of the nervous system at the proximal end of the resection. And I want to share this paper because this was published back in 2019 by the American Pediatrics Surgical Association Hirschsprung Disease Interest Group. And many of these folks here are, if not all, are pathologists who sort of came together to help in the reporting of this resection type. And you can see here they use the technique, the different findings, where you found the ganglion cells, and then any comments, if you have seromuscular, submucosal, or full thickness biopsy, essentially 1 page to explain all of the things that are found at the time of resection. And here is another table that sort of just goes through all of the things that I just went through, but essentially for what is required of you for a diagnostic rectal biopsy, a seromuscular or full thickness biopsy, bowel resection, osteotomy, or redo pull-through. One note about, and now moving on to Hirschsprung-associated enterocolitis, is that the incidence can be up to 50%. So if you see enterocolitis or active inflammation in your rectal suction biopsy, it behooves you to tell the clinician because it is the leading cause of mortality in patients with Hirschsprung disease, characterized by fever, abdominal distension, diarrhea, colicky pain, and sepsis. And usually these patients will be sick before you even get the biopsy. But if you do see the inflammation, you should tell them, particularly in your resections as well. And then the preoperative risk is associated with congenital malformation and low birth weight, and the postoperative risk, of course, is associated with intestinal obstruction. Just to mention that there are differential diagnoses in Hirschsprung disease, things like intestinal neuronal dysplasia, ganglioneuromatosis, isolated hypoganglionosis. Of course, we talked about immature ganglia, the absence of argophil plexus, internal and anal sphincter achalasia, and megacystitis. But this is like a genetic syndrome, a well-known genetic syndrome. So there are options for when you have some concern. You see here, you can do different types of stains in order to help you narrow down that diagnosis. If you do suspect something besides what I classically describe here as Hirschsprung disease. And just some quick examples of advances in Hirschsprung disease. We're using now regenerative medicine like stem cell therapy to generate enteric neural progenitors from human pluripotent stem cells. And I thought this was quite interesting because here is a human intestinal organoid with transplanted. So here's the intestinal organoid without any ganglion cells or without any enteric nervous system. And then here is that same organoid when they transplanted these neural crest type cells. And you can see here in green that they start to innervate. Or at least you start seeing neurons. So it might be interesting to see as time progresses. I know that people have been working on this, and this is an older paper from 2017, but there are newer folks doing this kind of transplantation to see if this would be helpful in patients who have Hirschsprung disease, particularly in those who cannot be reoperated on. And so in summary, what are we doing with Hirschsprung disease? It's a functional intestinal obstruction, predominantly in neonates. Many of them are short segments. It's important to identify the lack of ganglion cells in making the diagnosis. Biopsy, of course, is the gold standard for identification. And immunohistochemistry, as I mentioned, is a useful adjunct, but be wary of the pitfalls. And that's it. I'm done. We have some time to have discussion if needed. I don't hear anyone. I don't see anything in the chat.
Thank you, Sonia.
Ah,
Okay.
I see. Sorry, there's a Q&A
Dr.
now.
Chen, maybe
Yeah,
we do
that's
have one question on Q&A.
Yeah, I see. Can
From
you do
Dirar.
diff quick on
He
FFP?
said,
I
can
mean,
we do the DIFQ in FFPE blocks?
I had never done diff
Not
quick
sure
on
if you have seen
FFP.
it.
I don't know if it can be done. We usually only do it on frozen sections. I have not really, I mean, people do it in cytopathology, sometimes, but I'm not really
Dr. Chen,
sure.
can you hear me?
Oh. Yes, I can hear you.
Yeah,
I've been
sorry.
answering. I'm
So,
sorry.
sorry.
No, it's okay. I'm saying that the diff quick on FFP blocks, I'm not quite sure. I have never done diff quick on anything but a frozen section. I'm not sure that it would have the same staining pattern, so I'm not sure. I do know that people use them sometimes in cytopathology, but I'm not sure if people have been using them in FFP blocks. That's all.
Thank you, Doctor.
No problem.
Okay. Okay, dear attendees, if you have any other question, comment, reflections on what Dr. Chen has presented on HST. Okay, Dr. Rahel, anything from you?
No, thank you very much, Sonia. That was a very nice descriptive presentation and very informative as well. Thank you.
Okay.
You're
Okay.
welcome. I feel like Hirschsprung's is it's a challenge. I think the hardest part of the Hirschsprung is in the frozen section room. How often do you guys get Hirschsprung for frozen?
In our institutional experience is very much limited for frozen. We only did a pilot project, and I'm not even sure if we did for Hirschsprungs, but almost no experience. Maybe other people in the group, if they have experience, they can say something. I guess not. No, not on fresh frozen. Rare, okay, there's one.
Well, you should come visit us so you can get some experience. I'm just kidding.
Okay. Okay. In that case, I think we can proceed to the next session. Okay. Okay, I don't see any hands, so I think basically we are left with 3 minutes, so we can safely proceed to the next session. Dr. Chen, would that be you or would that be Dr. Diana?
I think it's Dr. Thomas because she's gonna do pediatric brain tumors.
Okay. Okay.
Hello, can you hear me?
Yes, yes, we can hear you, Dr. Thomas.
Hi, let me share my screen. Oh, it looks like I don't have the ability to screen share.
See, I just made you co-host. Can you try again?
Okay.
Yep. Here you go.
Are you still able to see my PowerPoint?
We are just seeing a blue screen right now.
Does it look okay?
It
No.
was there and it disappeared.
Oh, let me
We
try
can
again.
see a desktop though. Now we see it.
Yes.
Okay.
You can just put it on the presentation mode. So, yep.
Is it in presentation mode now?
2 seconds. Not yet. Not yet.
Okay. Apologies.
It looked like the button was clicked, but it just didn't change the presentation, if that makes any sense.
I just tried
Yes.
again.
Yep. You are good to go.
Great. Okay, thank you so much. So my name is Diana Thomas. I'm a neuropathologist. I train in both adult and pediatric neuropathology. And I'm not a pediatric pathologist, so I just learned a lot about Hirschsprung's disease as well. I would be curious, similar question as before, how many pediatric brain tumor cases do you see at your institution? And I guess I would say pediatric, adolescent, and young adult.
Thank you, Dr. Thomas. I don't have the numbers on me right now, but we do see a lot of low-grade brain tumors and some medulloblastomas as well.
Okay.
But I'm not exactly sure on the number. Maybe I can check.
Okay, I just wanted to get a sense if this is, if you ever see these or if it's like extraordinarily rare. Thank you. So I chose to, it was impossible to fit all of pediatric neuropathology or brain tumors into one lecture. So I decided to focus on pediatric type low-grade gliomas and glioneuronal tumors that are sort of newly defined as per the most recent WHO classification. I think these are some of the toughest tumors to diagnose, in part because there's so much histologic overlap between entities, and also because accurate diagnosis often requires comprehensive molecular characterization, which is not always available for various reasons. So I have some background, but also wanted to just show some cases that we have encountered here at Nationwide Children's Hospital, and show some examples of sort of classic cases of these newly defined entities, and also some unusual variants that we have seen here that sort of threw us off track before we figured out the final diagnosis. So my slides are not advancing now. There we go. So we are currently using the 5th edition of the WHO classification of CNS tumors. And as you can see in this picture, there's been quite a jump over the years in the size of this book, which really reflects the complexity of the tumors it characterizes. And a large part of this increase in size and total number of tumor types that are described is the recent division of these diffuse or circumscribed gliomas into pediatric type and adult type. And there are now a number of entities that really are just recognized to occur in younger individuals. That's not to say they can't occur in adults, but they primarily occur in younger individuals and have very different molecular characteristics than adult tumors. As I mentioned, there's much more emphasis now on molecular features, and for some diagnoses, pretty advanced techniques are required to make these diagnoses. But this current version does not recommend at this point specific testing methods, which is in some ways good, but in some ways presents challenges because everyone is using different methods, depending on what's available. And then finally, one of the newest developments in the diagnosis and grading of brain tumors is this concept of integrated histologic and molecular grading schemes. So there's still a lot of reliance on histologic features, for example, mitotic rate and the presence of necrosis and microvascular proliferation, for example. But we now recognize, especially in pediatric tumors, these features have a lot less significance. and so don't automatically correspond to a high-grade tumor. Furthermore, with molecular characterization, we now know that for some tumor types, for example, IDH mutant astrocytomas, really regardless of their histologic grade, when you look at the H&E, if they have the presence of a CDKN2A or B homozygous deletion, the grade is automatically a grade 4, and we know that those tumors behave quite aggressively, regardless if they have a low-grade histologic appearance. So the field has really moved to using these layered integrated diagnoses, and the goal, of course, is to integrate the histologic and molecular information into an integrated diagnosis. I would say this is extremely important for especially pediatric tumors. So, for example, tumors that may have histopathologically been classified as oligodendrogliomas in the past, we now know that there are many pediatric tumors in particular that have an oligodendroglioma-like appearance, and we really need some molecular information to help sort them into the proper categories. So, for example, this tumor was found to have an FGFR1 tyrosine kinase domain duplication, and therefore fits best into the category of diffuse low-grade gliomas MAPK pathway altered. And so, this has a very different prognosis and natural behavior compared to oligodendrogliomas and other low-grade gliomas. So in the latest WHO classification, there were about 20 newly recognized tumor types. The ones in the box here I've highlighted are all the glial and glioneuronal tumors. And then you can see there are certainly ependymomas and embryonal tumors that have also been sort of newly called out based on a lot of molecular features. I wanted to focus today just on the lower grade gliomas in this list. So, but I will quickly sort of review where those fit into the larger scheme. So we still have our the classifications of typical adult type diffuse gliomas. So astrocytoma IDH mutant, oligodendroglioma that has IDH mutant and 1p19q codeletion, and then glioblastoma, which are IDH wild type. But now we have these new categories, and quite a number of them, of pediatric type diffuse gliomas, and they've been split into low grade and high grade gliomas. And the ones I've put in blue here are essentially newly recognized tumor types that are officially newly recognized since 2021. Then there's also the circumscribed astrocytic gliomas. Many of these occur in pediatrics, not most of them. And they have some interesting features that unfortunately I won't be able to cover today, but and then the last category are the glioneuronal and neuronal tumors. And again, there are several new entities here in blue that were probably previously misdiagnosed as a whole range of different tumors, but now it's really important to identify these because they have much different prognosis than higher grade tumors, which these can sometimes resemble. So of course, this sort of evolution into these integrated diagnoses has really resulted from a lot of large scale studies of pediatric tumors that, before we just didn't have the data, and now we do. And it's now well recognized that different genetic alterations can be characterized as low risk, intermediate risk, and high risk. And so the tumors I'll be talking about today mostly fall in this green section here with MIB-MIB-L1 fusions, FGFR2 fusions, BRAF, FGFR1, tandem tyrosine kinase domain duplications and fusions. And as you can see here, these do separate quite clearly into high, intermediate, and low risk groups based on these molecular alterations. And then, of course, the evolution of DNA methylation has also allowed us to further characterize and subclassify many of these tumors. And of course, this is the initial paper with 82 CNS tumor methylation classes that had distinct methylome features, and now we're well over 100, maybe 150 classes at this point. I'm not even sure. So going back to some cases. So many of these are cases that we have seen here at Nationwide Children's. And as I mentioned, in some cases have been a bit challenging. So this first case is a left frontal lobe lesion that occurred in a young adult. We do characterize young adults as up to 39. And this patient had had epilepsy since age 3. And you can see this flare lesion in the left frontal lobe. That's fairly well defined. It does not, it appears to be mostly centered in the white matter, but also involving the cortex. And it's a very interesting tumor because there are areas that are actually quite hypocellular, and you question, is this even a neoplasm, or am I in just a reactive, area? But when you look closer, there's the proportion of, astrocytes to oligodendrocytes here isn't quite right. And then looking around more, there are areas like this that are a lot higher cellularity, and the tumor cells, or the hypercellularity, seems to be due to these very small round cells that appear quite bland and monomorphic, and they're diffusely infiltrating here into the cortex. You can see some neurons in the background. This microcystic change in the neuropil is also quite common in this entity, but overall a very bland appearing tumor. Shown here at higher power, again, the tumor cells very, very monomorphic, scant cytoplasm, and mitotic activity is extremely hard to find if present at all. This is a neurofilament stain, which always helps to determine if it's truly an infiltrative tumor or not. So this is highlighting background processes that the tumor is infiltrating through. And interestingly, many of these tumors, although they are glial, do not express the OLIG2 glial marker. And so you can see here, most of the cells are negative, and these are probably normal astrocytes or in the background. So at this point, the best diagnosis to make is a diffuse low-grade glioma, and the comment saying that molecular testing is needed to further classify this tumor. And this is because the differential diagnosis is still quite broad at this point. We do have some clues in that OLIG2 stain was negative. That is not always seen, but often seen in these tumors with MIB or MIB-L1 fusions, which this tumor did have. These are transcriptional transactivators that are important for cell proliferation, and the detection of this can be accomplished through various techniques, but it's important to identify this fusion because it's a grade 1 tumor. These are very indolent tumors. Gross total resection is usually curative. They usually do not need additional therapy. In contrast, prior to 2021, we probably would have called this a diffuse astrocytoma, WHO grade 2. This patient may have received further therapy, and it has a different prognosis for that patient. And of course, it's also important in these cases to rule out that there's no IDH1 mutation or histone mutation. This is taken directly from the WHO book about the essential criteria. There really should be no histologic features of anaplasia, although I will say that we have seen very rare cases that had very high grade appearing histologic features, and these were occurring in a very young child, in less than 2 years of age. And it did have a MIB fusion and classified with these tumors on DNA methylation. So I think it is still a little unclear if these, can ever have anaplastic features, but the vast majority of them appear very low grade. And it's very helpful to look for the absence of OLIG2 expression. And we do not use MAP2 here, but there's also absence of MAP2 expression. These represent about 2% of pediatric low-grade gliomas. They're often epilepsy associated. The range can be from quite young until young adults. Median age is 10. As I showed on the MRI, the T2 flare signal often involves both the subcortical and cortical components and can show cystic change, making you think that perhaps this is, something else. They're usually cerebral, but we have seen very rare examples in the brainstem. And there's a lot of overlap with this entity with angiocentric gliomas as well, that also have MIB-L1 fusions. These, as I mentioned, have very benign clinical behavior, and these patients do very well and become seizure-free after a tumor resection. And I think I've basically mentioned all of this already, but these tumor cells are positive for GFAP, but negative for OLIG2, at least in a subset of cases, not all cases. Other important stains to do are ATRX. If that's lost, you would want to consider perhaps a higher grade diffuse astrocytoma, or maybe an IDH mutant astrocytoma. CD34 should be negative. We use that marker. It's often positive in glioneuronal tumors. So if you're not sure if the neurons you're seeing are entrapped normal neurons or glioneuronal tumor, CD34 can be a helpful stain. And P53 should be negative as well. And then this is just showing the location of these MIB and MIB-L1 altered tumors. Most of them are supratentorial. Occasionally they can be found in the brainstem. And the overall survival here for both groups are these red lines here, and there's nearly 100% survival. So good prognosis. So it's important to identify these from other low-grade diffuse astrocytomas. So moving on to the next case, this is a 10-year-old who also has epilepsy, and that's sort of a theme among these low-grade glial and glioneuronal tumors, that these patients often do present with seizures or have a history of a seizure disorder. This is a solid and cystic tumor, T2 hyperintense. And on resection, there was really a remarkable amount of calcification in this tumor. And it was actually hard to cut through it when I grossed it. So you see in between these calcifications, these round, rather monomorphic cells. In this area, they have sort of an oligodendroglioma-like appearance with this perinuclear clearing and very round, monotonous nuclei. And as I mentioned, calcification is a feature of this tumor. So even vessels and neurons can show calcification at times. And in some areas, they do appear a little more hypercellular and a little bit more pleomorphic. You have these larger cells, but I've never seen mitosis I've never seen microvascular proliferation or necrosis. CD34 is often really strongly and diffusely positive in these tumors, as seen in the bottom part of the screen. And they are at least somewhat infiltrative, but in contrast to the last tumor I showed, the MIB-L1 altered tumor, neurofilament staining does highlight some background processes, but it does appear to be more of an expansile compact lesion, at least in some areas, although there is at least some areas of diffuse growth. So the differential diagnosis here are really any of the low-grade gliomas or glioneuronal tumors that can show oligodendroglioma-like features. So that would, of course, include oligodendrogliomas. So you would want to assess for IDH mutations and 1p19q co-deletion. It could also still be a diffuse astrocytoma. There are areas that resembled astrocytoma more than oligo. Again, IDH mutations, it would be important to test for. DNET, this embryoplastic neuroepithelial tumor, is also consideration, especially due to the location of being a sort of a cortical and subcortical-based solid and cystic tumor. But we did not see floating neurons in this case. Gangliogliomas, because of the both sort of evidence of both neuronal and glial differentiation occasionally. However, gangliogliomas generally show less calcification than this, are less infiltrative, and may show a BRAF mutation. And then finally, plenty, which is actually what this tumor is. It shows strong diffuse CD34 staining, and we know that these usually have either a BRAF V600E mutation, which tends to occur in older young adults and teenagers, whereas the FGFR2 fusions and 3 fusions tend to occur in the younger children. So this is a tumor where additional molecular profiling is really helpful to further classify this tumor. And determine if it has a BRAF mutation or an FGFR fusion. Similar to the last tumor type, these are also very indolent cerebral neoplasms and associated with seizures. There's a hint that of a diagnosis when you see really dense calcification, or essentially a rock in the brain for some of these tumors, and they're often in the temporal lobe. They show often diffuse and compact growth patterns, and I already mentioned that they have the oligodendroglioma-like components, but also can show perivascular pseudorosettes similar to an ependymoma. Dense calcifications, and as I mentioned, CD34 immunoreactivity is very helpful. We have seen that even though this is characterized as a glioma, we have seen many, many examples where there are neuronal components in these tumors. And I'll show you some examples of that. And I assume that future iterations of the classification will specify that both glial and neuronal differentiation can be seen. So this is just taken out of the Blue Book on the exact criteria that are essential and desirable for making the diagnosis of a plenty. And as you can see here, it really does require at least some immunohistochemistry or further molecular testing to define the molecular diagnostic features of plenty. So as I mentioned, the WHO classification does not mention that that plenties can have neuronal differentiation, but if you, this is actually 3 examples of plenty we've seen here at Nationwide. You can see again the oligo-like features, there's astrocytic features, and then there's areas that are actually can be quite pleomorphic. And in the yellow star box here, this is a new end stain, so it's showing how you can get these nodules of neuronal cells in these supposedly glioma tumors. This is another one that had new N expression, and then the 3rd example over here of new N expression in these plenties. And all 3 of these tumors have confirmed FGFR2 fusions. And all 3 of these patients are doing very well after surgical resection, and it's been several years out now. So moving on to case 3, this is again a child with epilepsy, in this case a 7-year-old, who has a temporal lobe lesion here that again looks like it's partially enhancing, and it looks like it may have some cystic component. And on H&E stain, there are areas that look both oligodendroglioma-like again, and then other areas that look quite astrocytic. And a little bit higher power here. Again, no features really concerning for aggressive behavior or high grade here. There are some neurons here that look like they're perhaps entrapped. A little bit higher power. And then up here at the top of the screen is the subarachnoid space. So this tumor is actually forming sort of these little clusters right under the subpial area, and then potentially also involving leptomeninges. But this is very characteristic to see diffuse growth and then subpial clustering of these tumor cells. So the differential diagnosis here is really any diffuse low-grade glioma, including astrocytic lineage and oligodendroglioma lineage tumors. And those would be sort of considered the adult type tumors, and then really any of the pediatric type diffuse gliomas. So this morphology would be consistent with the MIB and MIB-L1 altered tumors that I already discussed, and also tumors that have a BRAF V600E or other MAPK pathway alterations. And so this is a tumor category at this point where molecular testing or surrogate IHC is really needed to reach a definitive diagnosis. And in this case, this tumor did show reactivity for BRAF V600E. And so this is consistent with this new entity that's been called, at least provisionally called, the diffuse low-grade glioma MAPK pathway altered. And it's probably to be expected that this name will change as different subtypes of this tumor, or different MAPK pathway alterations are identified, that this may be further split into additional groups. But these are interesting gliomas because they can show both astrocytic and oligodendroglioma or oligodendroglial morphology. As I mentioned, they typically occur in childhood. And really any tumor that has a MAPK pathway alteration can fit sort of into this category. So it's sort of a wastebasket in some sense. So these can have alterations in FGFR1, BRAF, and other MAPK pathway molecules. It's important to make sure that these are IDH wild type and H3 wild type, because that would put them into a different category. And then the differential diagnosis is really any diffuse low-grade glioma that can have an FGFR1 alteration. So, for example, DNAT plenty, and even some IDH mutant oligodendrogliomas could also be considered here. These tumors, as I mentioned, probably represent actually several subgroups of tumors, and they can be identified or sort of broken out by methylation profile. And at this point, due to the limited data that are available, there's no WHO grade that's currently assigned, although they do seem to behave low grade and probably somewhere, grade 1 or grade 2, based on the information we have at this point. This is, again, taken from the book, the summary of this entity. You want to find a diffuse glioma with absent or minimal mitotic activity, no microvascular proliferation, and nor necrosis. And it's important to identify both a MAPK pathway alteration and absence of features that would make it high grade, which is the homozygous deletion of CDKN2A. Okay, moving on to the next case. I don't have imaging for this one, but this is an 8-year-old boy that presented with a very large heterogeneous intraparenchymal mass in the parietal lobe that actually extended into the thalamus and then across the corpus callosum and crossed midline. It was enhancing and very concerning for a high-grade glioma. And this is a representative H&E stain. So you can see, again, this tumor has really dense calcifications. And then there are clusters of tumor, hypercellular areas of tumor cells scattered about. On higher power, this was a very polymorphous tumor. So there are cells that have this oligodendroglioma-like appearance, again, very small round cells, maybe even with a neurocytic type appearance. And then there are areas with these very pleomorphic, very large, often multinucleated cells. And mitotic activity can be found in these tumors, which really led us to believe that this could be a high-grade tumor. That was also confirmed or supported by the fact that it had a very high, not a high, but intermediate to high Ki-67 proliferation index. And there was loss of ATRX staining in this particular example, although this is not common, making us think that this may be a high-grade glioma, especially with its imaging features of crossing the midline. So we were concerned that this might be a high-grade astrocytoma with possibly a histone mutation, because they can also show that those large pleomorphic cells, or CNS neuroblastoma. But we weren't really sure. And actually, this patient went with a very descriptive diagnosis for several years until the clinicians questioned, this really is not behaving like a high-grade glioma. And so at that point, we had methylation profiling available. And so we recharacterized this tumor and realized it fell into this cluster of tumors that we called DGONC, or diffuse glioneuronal tumor with oligodendroglioma-like features and nuclear clusters. So this is really an interesting tumor because it is molecularly defined. And in the initial paper that described these, you can see the whole range of different diagnoses that this entity was given, even though they share a common methylation signature. So many of these look very high grade, but actually behave like a low grade tumor. The features are both glial and neuronal differentiation. As mentioned in the name of the very long and hard to say name, they often have these nuclear clusters and an oligodendroglioma-like component, and they frequently have recurrent monosomy 14. These are often supratentorial and typically in pediatric patients, although we have seen them in young adults as well. And even one patient up to age 75 was reported to have this. They have those scattered multinucleated cells that are almost reminiscent of ones you can see in a pilocytic astrocytoma. And they can be very large and pleomorphic. We've seen cases where the mitotic frequency is quite high, very brisk, and appears very undifferentiated, which can really lead you to think that this is a high-grade tumor. And these calcifications are very common again and can give a clue that maybe this is a degonc or a lower grade tumor. So this, these are the essential and desirable criteria of degonc. But what's challenging about this tumor is that methylation is really the only method so far that clearly identifies this tumor type. And as it's not widely available, this presents a challenge to making this diagnosis. So in cases that don't seem to really fit into other categories, I think it's very helpful to consider degonc. I will also say it is extremely, the histologic features, well, often have this oligodendroglioma-like morphology. We have seen many cases that actually appear more embryonal in nature, small blue cell tumor and also high-grade glioma, high-grade astrocytoma appearance. So these are very tricky tumors. But it is helpful to identify these because these patients really may not need aggressive therapy. We don't know yet because many of these patients actually were treated with radiation and chemotherapy, thinking it was a high-grade tumor at the time. But these patients have a much, much better survival than patients with high-grade glioma. Okay, I think I have 2 cases left. This is case 5 is a 24-year-old that presented with headaches, emesis, and seizures and has this very complex mass in the midline. On the H&E, it's a moderately cellular tumor composed again of small, very monomorphic blue cells. So it's again got that sort of oligodendroglioma-like appearance. These often have a myxoid stroma and a very delicate capillary network. You can see floating neurons, neurocytic rosettes. And here it is a little bit higher power. The immunophenotype is sort of what you would expect. These are positive for glial markers and neuronal markers. However, it is CD34 negative, which would argue against this being a plenty or a ganglioglioma, and they are IDH negative, helping to exclude an oligodendroglioma. So in this location and with this histologic appearance, there's really 3 tumors to consider here. One is a myxoid glioneuronal tumor, which is a newly defined tumor type. Another is a DNET, although this location in the midline is less common for DNET. Usually they're superficial and cortically based. And then rosette-forming glioneuronal tumors, which they have a similar, very low-grade appearance and often occur in the midline as well, and near the ventricular system. So in this case, the diagnosis was really only made because we were able to sequence this tumor, and a solitary PDGFR-A gene mutation was found at this particular site. And this is characteristic of this entity, the myxoid glioneuronal tumor, CNS grade 1. These are tumors that actually appear very much like a DNET, but they arise around the septal nuclei, the septum pellucidum, corpus callosum, or periventricular white matter. So unlike DNET that are more cortically based, these are right along the ventricular system and often along the septum pellucidum. These are circumscribed, non-infiltrative, and again, have that myxoid stroma with a proliferation of very bland oligodendrocyte-like tumor cells. And then really the identification of this mutation in codon 385 in the PDGFR-A gene is important for making the diagnosis. They also cluster into a unique group on methylation profiling. This is an extremely rare tumor. I've only seen a couple of examples. And it occurs in a little bit older children and young adults. I haven't seen any cases in infants. I think they're extremely rare. But again, these are very indolent tumors with favorable long-term outcomes in the absence of radiotherapy and chemotherapy. Although some have recurred or disseminated throughout the ventricular system after subtotal resection. But even in those cases, those patients tend to still do very well. So the essential criteria are those oligodendrocyte-like tumor cells in the myxoid stroma, and then importantly, really the location has to be midline. It is very helpful to identify that PDGFRA mutation or perform methylation profiling to confirm the diagnosis when available. And then I believe this is my last case. This is a 42-year-old who presented with seizures, and again has a parietal lesion. This has a very characteristic morphology where there are these discrete nodules of tumor, with very mature appearing neurons scattered throughout the neuropil, separated by white matter that is not normal. It is hypercellular. And then within the nodules, there's this characteristic vacuolar change to the matrix, seen here as well. So this is not spongiosis. This is actually a tumor. These neurons are synaptophysin and OLIG2 immunoreactive, which is interesting to have that profile. CD34 can also highlight some background cells. And this diagnosis can almost be made on H&E and some simple stains like a Luxol Fast Blue to help identify the nodules, because there should be multiple nodules. They should see that vacuolating background. These tumors can actually occur across a huge spectrum of pediatric and adult patients, again, often associated with seizures. They can be actually incidentally discovered, and the patient may be completely asymptomatic, and these patients do very well. So here's a couple of examples. Again, these are very superficially located, and on gross examination, you can almost make this diagnosis. It really looks like a heterotopia almost, within the white matter there, and on the stain here that's highlighting myelin. Same here. If you look very carefully along the gray-white interface here, there's some irregularity, and that represents the nodules that we're seeing on H&E. Again, very superficially located tumors. So the essential criteria is that it really should be multinodular, that it should have neuronal cytologic features. It can also have a glial marker immunoreactivity. These are very low grade. They really should have no mitotic activity, and they should have that vacuolation of the matrix. And then there's some desirable, but I think this is actually a fairly straightforward diagnosis to make, and molecular testing is not always needed. However, if it is done, the most commonly found alterations are again in the MAPK pathway, which is a common theme here of these low-grade gliomas. Interestingly, they often have pathogenic mutations in BRAF, but they're different than the V600E that we see in so many other tumor types. And again, could have FGFR2 fusions. So certainly would want to consider other tumors like plenty as well in your differential. So I got through this pretty quick, so that there will be time for questions if there are any. But in summary, we now have these new categories of pediatric type diffuse low-grade gliomas and glioneuronal tumors that have characteristic molecular alterations. But when there is a suspicion for these, it's important to make the diagnosis, because these are low-grade. Even if they have high-grade features, all of these tumors can behave very low-grade and indolent, and we don't want to overtreat these children and young adults and put them at risk for secondary tumors later in life. So the CNS tumor classification continues to be a work in progress. I assume that we'll have another edition coming in the next several years. Who knows how thick that book will be, but as this field continues to grow, we will continue to probably see more and more entities, and some of the provisional entities that are currently in the WHO will probably be added as official entities in the next edition. So thank you so much for your time, and I'm happy to try to answer any questions.
Thank you very much, Dr. Thomas. I think we had one question from Dr. Azeb on the chat box. I think she said that, is there any way that helps in the absence of molecular study? I'm not sure what they refers to here, but Dr. Azeb, if you can elaborate this question.
I'm not sure which tumor type that question was in reference to, but it is very challenging. And I think I tried to highlight some of the immunostains that are helpful. And I think most importantly, it's helpful to have a high index of suspicion that a tumor, especially in a young patient, even if it has high grade features, that it could be a low grade tumor, and to have that clinical pathologic correlation that perhaps the clinical team can then consider that this is not a high grade tumor, and delay treatment until there's evidence that it really is going to behave like a higher grade tumor. But I agree, it is very challenging when there's a lack of readily available molecular testing for some of these entities. And in that case, I think it is completely appropriate to use the categories of low-grade glioma, not otherwise specified, and the WHO recognizes that's still a completely adequate diagnosis in many situations.
Thank you, Dr. Thomas, for clarifying that. Dear attendees, if you have any other question for Dr. Diana before she proceeds to the next presentation, or any reflections from colleagues, from team members of Ethiopian Society of Pathology.
I just don't know how you can keep all the molecular together. I feel like it's too hard.
It's coming for every area of pathology.
Yes, I know.
Yes.
Okay. I don't think there are any other comments or questions from the last presentation. Okay, one just came in, Dr. Abdul Qadir. Can we call PLTY? I'm not sure what that refers to, but without immunohistochemistry, or better to call low-grade glioma with oligo-like features. That is in the chat box, Dr. Thomas.
Yeah, so I think I would definitely raise, I may not call it plenty if I'm not able to do a CD34 stain, but I think it's good to do to suggest that it's possible. I mean, these tumors have very characteristic locations in the temporal lobe. If they have the calcifications and have the algo-like features, and sometimes those perivascular pseudo-rosettes, things like that. If there's that constellation of features, I think it is very appropriate to suggest that diagnosis in a comment, for example. And these tumors, I think, are a lot more common than previously recognized. These probably were called diffuse low-grade gliomas in the past, or gangliogliomas. So, I think that they're very common. And so I think it's good to raise consideration of that, even if you don't have immunostains to confirm the diagnosis.
Thank you for your question, Dr. Abdul Qadir. Okay. I think we can proceed, Dr. Thomas. Next up is germ cell tumor setting.
Should we move on to the next lecture or?
Yes, I think we should. I think
Okay,
next up is
Sonia, would you like to start and I will do the second half?
Sounds good. Let me share my screen. All right, I hope you can see everything right now. So Diana, Dr. Thomas and I are going to do a tag team today. I am really going to talk mostly about non-CNS germ cell tumors, and she's definitely going to talk all about CNS germ cell tumors. So let's just begin. Just as a way to sort of introduce the entire topic. So human germ cell tumors are derived from stem cells of the early embryo and the germline, and the vast majority of them occur in the gonads. They're the primary germ cell tumors, and compared to ovary versus testis, testicular tumors definitely far much more common. And then when we think about things that are outside of the gonads, the extragonadal tumors, which is really what we are going to talk about today, they represent about 5% of all germ cell tumors. So we're looking at a very small subset of tumors. And they occur, as you can see here from the developing embryo, anywhere along the area that primordial germ cells are located during embryogenesis and as they migrate. So you can find them anywhere from the yolk sac area, all down into the sacral region, obviously into the gonads, along the gastrointestinal tract, along the spine, along the neck, and all the way into the brain. And so that gives us many locations that I've mentioned here, which is retroperitoneal, mediastinal, sacrococcygeal, head and neck, and brain. And then when we look at the most recent cancer registries here in the US, we can see that obviously gonadal germ cell tumors have the highest incidence, but also in the ages of 15 to 19. So we're looking at older children. When we look at younger children, you can see that the extracranial, extragonadal germ cell tumors, particularly in the babies less than 1 year of age, that's the most predominant tumor. And then when we think of intracranial and intraspinal germ cell tumors that Diana will be talking about, you can see that there is a variability in terms of the incidence rate over the different age groups. So, and as I mentioned, I'm not going to be focusing at all on any of the gonadal germ cell tumors. So I like to go back to biology. So there's 7 different types of germ cell tumor that have been described, go from type 0 all the way to type 6 in Roman numerals. And you can see that depending on it's really dependent on the age, and the incidence, as you can see also, is kind of low when you look at it per 100,000 people, but only in the reproductive age do you start getting really higher numbers. And again, the different types relate to the different expressions of what we'll see histologically, and also related to this different site that is going to be involved. And then if you think about the cell of origin, here I've put the germ cell types here, 0, 1, 2 to 6. And then you think of the different cell of origins and what they actually do. There's a box right here that talks about what happens, right? So initially you have the cell, and then the cell gets reprogrammed. And when the cell gets reprogrammed, then it can develop into a tumor. And so the mechanism of reprogramming is in this area here, which I'm going to block out because it's very complicated, and don't have time in this short period to actually talk about it. But we're going to talk just briefly about which ones and what happens. So you start off with a blastomere, you have a primordial germ cell that continues to develop, and eventually you develop into an embryonic stem cell. And that stem cell is really what can make all the difference, or it's, otherwise, once it's transformed, it becomes an embryonal carcinoma cell. So, as these cells develop, the primordial germ cells develop, if they become transformed or reprogrammed by whatever mechanism, usually, obviously, it's due to a molecular underpinning, they become stem cells, and it's that stemness that results in tumor development. So when you go from a blastomere, you can have a twin embryo, and that gives you a parasitic twin. If you have an early progenitor cell, it becomes a primed stem cell, and that can give you teratoma or yolk sac tumor. Same thing with the late progenitor cell, you start getting seminomas and non-seminomas. If you had a spermatogonium, it doesn't get reprogrammed and actually turns into spermatocytic tumor. We know that these are fairly well behaved and happen in much older age groups in patients over 70. The primary oocyte turns into the gynogenote, and that gives you a dermoid. Same thing for empty ovum, gives you a hydatid mole, and then the primordial cell also gives, well, from a somatic cell, then you have a immature teratoma, yolk sac tumor, or non-seminoma. And so just to give you an idea that, essentially these germ cells become transformed, usually because they've lost their way, and then they eventually turn into one of these, or develop into one of these tumors. And so I'm going to really focus on this area of the graph and not these older age groups, obviously, because we are doing pediatric type extragonadal germ cell tumors. And so here, just to kind of go through, is extragonadal subtypes by age group. And this is just another way to look at it. So you can think about them as congenital, neonatal, or type 1, which is birth to 6 months, childhood, prepubertal, or type 1, which is 7 months to 10 years, and adolescent or adults, which is postpubertal, also known as type 2, greater than 11 years. And this cutoff of 10 to 11 years was established by a study, I think back in 1990, just that's the best time to have as a cutoff, because they're much more, these adult type postpubertal much more frequently occur in children at or over 11 years of age. Although you can see prepubertal type lesions in patients that are adults and postpubertal type lesions in infants and children. This just, somewhat of just a cutoff to kind of fit things into a box, as it were. And then one note on molecular differentiation, and then I will not talk about it again, but isochromosome 12p is present in postpubertal germ cell tumors. So if you have concern, because these postpubertal germ cell tumors are the ones that most likely will develop somatic malignancy, and as a result, some folks want to know whether or not there's isochromosome 12p present, and as a result, you may have to do molecular testing to identify it. And as an aside, if you have isochromosome 12p, even in a patient who is prepubertal, that would be considered a postpubertal germ cell tumor on the basis of molecular differentiation. So what are some of the features of extragonadal germ cell tumors that I mentioned to you in these brackets? Well, from birth to 6 months, really and truly, you see a lot of sacrococcygeal, head and neck, and retroperitoneal tumors. All sites appear to behave similarly. Most are teratomas, plus or minus yolk sac tumor, and there's a conservative approach with follow-up after surgical excision. In the patients who are between 7 months and 10 years, those are actually very rare tumors. Most of them, though, contain yolk sac tumor, and more frequently, they have aggressive behavior. They have a worse prognosis than in the neonatal group. And the retroperitoneal lesions are not derived from an occult gonadal primary. So when you think about gonadal primary germ cell tumors, they typically occur in the gonads and can metastasize to areas in the retroperitoneum. However, in a child, if you found a retroperitoneal lesion, it's probably due to not metastasis, but actually those germ cells that just lost their way and got stuck in the retroperitoneum, developing into a tumor after being reprogrammed. And then finally, and the adult and adolescent type 2, they may all be associated with the development of any of the non-germ cell neoplasms as well. You can develop squamous cell carcinoma, rhabdomyosarcoma, carcinomas and sarcomas being the most common somatic malignant transformation. And then of course, non-seminomatous extragonadal germ cell tumors in this group are considered poor risk, and the site of disease really doesn't impact the prognosis in these seminomatous extragonadal germ cell tumors. And that's just to note, mediastinal extragonadal germ cell tumors, including those in the thymus. Commonly, we see mature teratoma, and that is benign, and it can be associated with hydatidiform mole, and it can also have isochromosome 12p alterations and share a common origin with patients who basically have post-pubertal lesions. That's usually when you see them. And then in the retroperitoneum, if they are in adults, most often they are derived from occult gonadal primary. Now, histologic subtypes of extragonadal germ cell tumors. I will draw your attention to this graph over here because this is very similar to the image that I showed you before, where you have your germ cells migrating to the gonads and in extragonadal locations. When they are transformed, you can have suppressed differentiation, and then meaning that they remain like germ cells, and so they develop into sort of what we classically think of the things that look like a normal germ cell, so seminoma or dysgerminoma. And then they may differentiate into the embryonal carcinoma cell, which gives it its stemness, and then it can develop into the embryonic types, which are mature or immature teratoma, or the extra embryonic types, which are choriocarcinoma and yolk sac tumor. So I will kind of touch briefly on each of these different types once we can see them. But the seminomatous type, we just keep in mind that they are usually always positive for the immunohistochemistry OCT4, SAL4, and Lin28, and they're negative for CD30 and alpha-fetoprotein. When we think of the non-seminomatous types, they obviously, as you can see over here, they encompass quite a number of things. But when we think about teratoma, mature or immature, you can actually see, obviously, keratins will be positive, but some alpha-fetoprotein is going to be positive as well. And Lin28, which is another marker simply of germ cell stemness, is positive in immature teratoma, and it will be negative for OCT4, so that will differentiate it from the seminoma. In embryonal carcinoma, because now we have gone a little further down the line of differentiation, you still have OCT4, SAL4, and Lin28. Sometimes you can get a little AFP weakly, but really and truly, the differentiating immunohistochemical marker is CD30. So you want to make sure that you order a CD30, or if you have it in your capability, but if not, there's histologic evidence of embryonal carcinoma as well. Can be negative for AFP and CD117 and Glypican-3. Now, when we go to yolk sac and choriocarcinoma, because they are different, they do still share that SAL4 and Lin28 that you see with all the germ cells. But because they're slightly different in terms of their differentiation, they now begin to express Glypican-3, and they also have a bit of AFP. They'll be negative for CD30 and negative for OCT4. So that really helps you differentiate the yolk sac tumors. And then the choriocarcinoma, of course, positive for HCG and sometimes positive for Glypican-3 with the same germ cell markers that all of these will have. And then they'll be negative for AFP, CD30, and OCT4. So I hope that this is just for you to see and know that, these are the classic phenotypes of these tumors. Needless to say, not all of them like to read the book, and they do like to be close to one another. So embryonal and yolk sac are not uncommonly found together. And then trying to figure out what is staining what can be challenging. And of course, if you have 2 or more histotypes in this histologic group, then you immediately call this a mixed germ cell tumor. So here are some case examples. First case is a 36-week-old twin male. He was born via C-section for pelvic mass that was identified on antenatal screening, and you can clearly see a mass here that is sort of projecting and making the skin looking irregular, very erythematous, but no tenting, and you can see his anus here. And then on imaging, it's quite easy to identify this large dumbbell-shaped multi-lobulated cystic mass. It's sitting right there. This is the pelvis, so it's sitting in the abdomen and hanging down through the pelvis, and is about 9 centimeters in its widest dimension. And they describe in the radiology as 50% of the mass is intrapelvic and the other 50% is extrapelvic, comprised of numerous thin-walled cysts and no dominant nodular or solid enhancing components post-contrast, no restricted diffusion, and the lesion, of course, being that size, displaces the bladder and the rectum. And so here is the gross specimen that has been excised, and you can see that it has this very dumbbell type shape to it. And on cross section, it has this yellowish appearance, maybe a vague thin capsule sort of around it, and looks almost like a sponge with little cysts, large and small, varying sizes. Nothing much in the way of necrosis, but there is some suggestion here that maybe there's something going on. It looks a bit liquefied, but not obvious necrosis and hemorrhage, maybe some punctate foci. Histologically, you can appreciate that there are a number of cystic spaces here with some kind of epithelium, and some of the epithelium is slightly different from others. You can also appreciate an area here of cartilage, and then this delicate sort of pale blue stuff in between, which is your primitive mesenchyme, which is in between. At higher magnification, I just want to show you that you have areas of cartilage with your primitive mesenchyme and some cysts lined by stratified sort of cuboidal epithelium. Some of them are pseudostratified columnar with cilia. So very, very reminiscent of what you expect. And then there are other areas which look just like what Diana showed not too long ago, a little bit of cerebellum. And here on some foci, you can also appreciate some neuroepithelium with some rosettes and a true lumen adjacent to these areas where there looks like there's mature neural or glial tissue nearby. And even this epithelium that looks columnar, pseudostratified with cilia on it. So again, all pointing to things that look very teratomatous. But I will show you 4 low power fields and you will tell me what you think. So here's a low power field, again, interspersed by lots of what looks like a mature glial tissue, lots of these cystic spaces, but also lots of these darker cells, which look like mature or immature neuroepithelium. And you can see it here again on another low power field, and again on another low power field, and again on another low power field. So that's right, Dr. Kirby. So that looks like immature teratoma, right? And it's all seen in one slide in 4 low power fields. So this was actually signed out as immature teratoma grade 3 or high grade at 9.7 centimeters, extending to the inked margins of resection, because you saw it, there's all a very thin little capsule at best. In that lesion. And then obviously there are definitely areas of mature teratoma. So why does it matter? We have immature teratoma. How are we going to make that the decision to call it grade 3 or high grade? So typically in the ovary and in the testis, we use this grading system, but in extragonadal germ cell tumors, you can also utilize the same gonadal grading system. So you see here it's grade 1, 2, or 3, and grade 1 is considered low grade, and 2 and 3 are considered high grade. So if you have low grade, you have none or limited to one focus in a low power field in one slide of immature teratoma, which I showed. If you have high, it's more than 1, but less than or equal to 3 foci identified on low power fields in any one slide. And then 4 or more foci identified on low power fields in any one slide is equal to high grade. So that's all that I showed you just now. It was easy to find more than 4 foci in low power fields on multiple slides in this particular case. And so this was called immature teratoma grade 3. And so let's move to what happens with these patients and with sacrococcygeal germ cell tumor, because it is the most common germ cell tumor of childhood. The incidence is 1 in 35,000 to 40,000 live births, and there is a female preponderance of 3 to 1. Most cases are diagnosed at the time of birth, and they are usually mature or immature teratomas, as in this case. Just a point to note that yolk sac tumors will occur more frequently in children over 1 year, and the rate of that is about 75%. But they can occur in the sacrococcygeal location. And they may occur in patients with anorectal malformation. We do have a very large clinic here for patients who have anorectal malformation, and it's not uncommon to find them with the teratoma as well as a presacral mass. So what's the treatment and what do we do? For finding a sacrococcygeal lesion, typically it is a surgical resection or coccygeal resection. And then if there is adjacent or concurrent yolk sac tumor, most people give chemotherapy. And of course, if there is recurrence, you get chemotherapy. Teratoma, as we know it, is not very chemosensitive. So as a result, surgical resection is usually the #1 curative procedure. And so patients most often will undergo a surgical resection first. You identify that it's teratoma plus or minus something else, and then they will undergo chemotherapy if there's additional components. And of course, if they have high-grade immature teratoma, more and more the oncologists are adding chemotherapy for those because they do tend to either recur or metastasize. Of course, we use baseline serum markers, LDH, AFP, and beta HCG baseline to monitor primary response to resection and for surveillance. And in general, for these patients, they have a 5-year event-free survival of about 69% and an overall survival of about 90%. And here you can see the different types of sacrococcygeal tumors. Here, type 1, most of it is outside of the body. Type 2, as in our patient, half of it is intrapelvic and half of it is extrapelvic. Type 3, the large majority of it is actually intrapelvic and intra-abdominal. And type 4, most of it is presacral and a very small lesion in compared to some of the other types. And obviously this the size of this lesion will predict the extent of the surgery as well. If they are diagnosed postnatally, it's usually associated with a good outcome. And if they're diagnosed prenatally, it's usually associated with significant morbidity and mortality. Usually that's because if you've seen it prenatally, it's growing. It's already very big and probably is, like this or bigger. And so that compressive action of this very large germ cell tumor results in high output cardiac failure. There's more time for this to grow, so the development of malignant histotypes is there. And then, of course, tumor rupture at delivery with hemorrhage is not uncommon. And so these patients may have to have a cesarean section to have a delivery in order to prevent tumor rupture, particularly if it is very, very large. And in Japan, there was a study done in 2009 where 16% of their infant mortality was as a result of prenatally diagnosed sacrococcygeal teratoma, which is a very large population if you just think about it. All right. Moving on to case number 2. If you have questions, I saw people have been writing in the chat. I'll keep my eye on the chat as much as possible. But I don't see any questions there in the chat. Oh, I see something in the Q&A. Low power is written as 40x in your slides for grading immature teratoma. Yes. So do you mean 4x? It is 40x. It's because when you have an objective multiplied by your 4x, so I have my eyepiece is 10x and the 4x is the 4x is the objective, then I multiplied it 2, and yes, it is considered 40x. So it's the same thing as if I said, yes, I'm using a 4x objective. And so the well, not the lowest, but the low power field of 4x is what I mean. Okay, so I'm gonna move to case number 2. I hope that answers your question. Case number 2 is a 7-year-old male with
Sorry,
Klinefelter syndrome who presents with a cough and a fever.
Sorry,
Imaging
Dr.
has
Lee.
identified a pneumonia and a concurrent anterior mediastinal mass. Okay. And of course, they imaged it and I don't think I thought I had a picture, but they imaged it and then they resected it. And as you can see here, it has a very glistening capsule. And when it's cut on cross section, very large cysts along with some smaller cysts and some firmer areas that doesn't look like there's a lot of papillary stuff in here, but they are kind of irregular and somewhat, when I can tell you on palpation, some of this stuff in between here seemed a bit firm and friable. And there were no areas of obvious hemorrhage, at least not in this. And so on histologic sections, you can appreciate these cystic cavities with different kinds of lining, some of which have, I'll go a little higher power. You can see a pseudostratified columnar epithelium with cilia, and you can see another sort of thinned epithelium. Another kind of thinned epithelium down here with some acute inflammation. Trying to get to the next one. And of course, that's a mature teratoma component. And then there were areas that looked like this. You can clearly see that there are large cells with a huge nucleus and a prominent nucleolus. They're sort of not a sort of regular pattern to them. It's kind of a solid proliferation. Some areas may be forming pseudotubules. And you can see that again here with a very large nucleus, prominent nucleolus, and sort of basophilic looking cytoplasm. In some areas, you can also appreciate that there was necrosis. Little foci, not a whole lot, so I just tried to zoom in on the little foci of necrosis, but right adjacent to your tumor, your lesion. So based on the histology, because I think the answer is coming up next. Based on the histology, I mean, what do people think that this represents? Very good. So mixed germ cell with embryonal carcinoma. And of course, I did my CD30 and it's clearly positive for CD30 in a very diffuse pattern. So embryonal carcinoma component. So yes, this was called malignant mixed germ cell tumor with mature teratoma in the majority of it. And there was a little component, a smaller component of embryonal carcinoma. We tend to, when we write these reports, include what percentage of each component is present, mostly because this determines some of the prognosis and what you may end up metastasizing. So while you might have a whole lot of mature teratoma, what might metastasize might be the embryonal component. And what you might find in your retroperitoneal lymph nodes, for example, might be mature teratoma component. So in this case, though, this is a mediastinal lesion. And yes, we do give chemo for embryonal. This subgroup is a subgroup site of primary extragonadal germ cell tumors, which is less commonly seen in children, accounts for 25% of mediastinal tumors in children and adults. And there's a known association with Klinefelter syndrome. Many patients present with cough, dyspnea, superior vena cava syndrome, and local pain. And the event-free survival is about 44%, whilst the overall survival is about 45%. So not a very good overall survival or event-free survival. Then I'm going to move to case number 3. So case number 3 is a 3-year-old female with vague abdominal pain and occasional constipation. And you can see this very, very large lesion here. that was considered to be as part of her retroperitoneum. And here's the lesion. I'm sorry, I thought I had an image of it unresected, but here's the lesion before it has been cut. I mean, after it has been cut into, and it's quite easy to see that's very variegated. You can see lots of cystic areas. You can see some necrosis, very open, open, multiple cystic areas, and certainly some solid areas here that you can see with necrosis. And histologically, this is a little easy, right? So we have very different histotypes scattered around here. Someone asked, in the case of mixed germ cell tumor, how exactly do you measure the percentage? You do not. It's a gestalt. How much do you think is present? Is usually what you do, how much you see on your slides. If you're concerned that there might be more, then you might have to go back and resample if you want to give a bigger percentage for something. But in general, we sample 1 per centimeter, one section per centimeter in these tumors, and then we see what we get. If there are areas that are more concerning after receiving the sections, like you see a very tiny focus of yolk sac, then you may go back and submit additional sections. So moving back to the case, you can
Dr.
see
Chain,
sorry.
sorry,
Yeah.
can we give Dr. Nimera a chance to speak?
Oh yeah,
Sorry.
but she said she
Okay.
can't speak in the chat.
No. I have allowed her.
Okay.
Dr. Nimera, if you have any question, you can please forward it. Dr. Nimera, do you have a question? Maybe it's an old hand or
Oh,
she posted it by mistake, so please proceed.
All right. Sounds good. All right, so back to this one. So multiple cystic areas lined by different epithelial types. Even at low power, you can see mucinous looking something here. This probably represents respiratory type epithelium. You can see pigmentation, smaller tubular-like structures here, and then open areas like this. So we'll see a little bit closer what they represent. And here in one area, you can actually appreciate something that looks like, does anybody know? You can add this in the chat. This one is for my residents. It kind of looks like salivary gland. This is actually a little bit of pancreas. So it has like asana and non-asana components with little ducts. So it looks like a little bit of pancreas. But salivary gland is also very similar. But overall, you have a mature teratoma component. In addition, there were foci like this. You can see that there are some little cystic spaces, some larger than others, so a bit of a macrocystic versus microcystic patterns. And there are areas that look like that, which on higher power, can anybody tell me what this structure might represent and what lesion I might be dealing with? Great, so Schiller-Duval. Yes, beautiful. So a really nice case with Schiller-Duval bodies, where you can see these tumor cells sort of lining up. So the Schiller-Duval body sort of looks almost glomeruloid. Essentially, they are floating cells within a small papillary structure. And on the outside of them, they're surrounded also by these similar cells. They've kind of fallen off here, but they're surrounded also by that cell. So you have a dual layer of these tumor cells. And they are very, very characteristic, obviously pathognomonic for the diagnosis. And here you can also appreciate these beautiful globules, which, I mean, even on frozen section, I have seen these sometimes and told folks to kind of suggest that maybe this is that tumor. And then we did a glypican-3 immunohistochemistry, and it was positive in that area. So what diagnosis am I making? Oh, I see a diagnosis already. Yeah, very good. In the chat says mature teratoma with yolk sac component. So very good. So malignant mixed cell, germ cell tumor. The yolk sac tumor in this case comprised about 50% of the lesion, and the mature teratoma another 50%. of the lesion. So let's talk about retroperitoneal germ cell tumors, and this comprises about 3 to 6% of all extragonadal germ cell tumors. Symptoms and signs are extremely non-specific. They can have constipation, vague abdominal pain or back pain, fever, weight loss. And commonly they're diagnosed when large and compressive. Complications include tumor rupture and spinal cord compression. And in the retroperitoneum for children, the most common histology is actually yolk sac tumor. The treatment is neoadjuvant chemotherapy, and of course, they may undergo surgical resection after that. And the event-free survival, 5 years, 42%, whereas overall survival is about 62%. Because this tumor can recur and metastasize. So that's usually what the problem is with yolk sac tumor. I think that's all I have for my area. Diana, you can, if someone wants to ask any questions, feel free, but Diana, you could go ahead and begin.
Are you able to see my presentation?
Yes.
Okay. Should I proceed, or are there any questions for Dr. Chen?
I think there is one from Dr. Brahanu. Quite mature in high grade for the first case. And Dr.
Yeah, it was
Firwis.
answered because there's much immature neuroepithelium present in more than 4 foci at low power on any given slide. And so that makes it grade 3 and a high grade.
Okay, Dr. Thomas, off you go.
Okay. So I'm going to round out this topic by talking about CNS germ cell tumors, which of course are very similar to what Dr. Chen just discussed. I think some significant differences are we don't have as sophisticated of grading systems in the CNS. And actually, there's very limited diagnoses that are made in part, in practicality. Sorry, I'm having trouble advancing my slides again. Oh, there we go. So really, there are just 3 main categories of diagnoses we make surrounding germ cell tumors in the CNS. Germinomas are the most common by far, pure germinomas, and followed by teratomas, which, similar to what was just discussed, fall into mature and immature categories. And then we always are screening for the possibility of a mixed malignant germ cell tumor with components of membranal yolk sac or choriocarcinoma that are often mixed with teratoma, most commonly. So these tumors are typically arise in the midline, in either the pineal region, the suprasellar region, or other less commonly, but still midline related structures such as the basal ganglia and thalamus. But really they can occur in any supratentorial or infratentorial location and the spinal cord. They can be solitary tumors, but it is not too uncommon to find multifocal tumors. So for example, in this MRI, we can see that this patient has both a suprasellar lesion and a pineal lesion. We do know that there's an increased risk, although not sure why, of CNS germ cell tumors in the setting of Klinefelter syndrome and in Down syndrome. So as I mentioned, germinoma is the most common. It represents about 2/3 of all intracranial germ cell tumors. These are typically found in adolescence and young adulthood. They're often in the pineal gland, especially in males. There's a very strong male predominance, about 90%, but can also be found in the pituitary and suprasellar regions, as I mentioned. Other sites can occur, but are very rare. The clinical presentation can be very highly variable, and it really depends on the tumor location. So For pineal-based tumors, patients often present with Parinaud syndrome due to compression of the brainstem and the tectal region, and hydrocephalus due to compression of the cerebral aqueduct. For suprasellar or sellar tumors that arise from the posterior pituitary or the stalk, these patients often have visual field defects due to impingement of the tumor onto the optic chiasm, and they may have endocrine issues with either due to hypopituitarism or diabetes insipidus due to disruption of the hypothalamic pituitary axis. In patients with tumors in the basal ganglia and thalami, these patients can present with hemiparesis. And interestingly, these patients can sometimes have a several-year history of symptoms in some cases, especially in cases of pituitary insufficiency. Precocious puberty has also been reported in many cases due to elevated HGC, and I will show you a case at the end, an interesting case that we had here at Nationwide. On MRI, germinomas have a very characteristic appearance. They have a solid appearance and appear hyperintense on T2 flare signal with very strong homogeneous enhancement. If there's heterogeneous enhancement, you immediately start to think, could this be a mixed germ cell tumor or something else? Usually there's a focal solitary lesion, but germinomas are known to spread right along the ventricular system. So in the rightmost image here, you can see this flare signal is surrounding the lateral ventricles, both the frontal horns and the occipital horns. And the tumor cells are really just sort of infiltrating along the subependymal region. Here's an autopsy image of a large germinoma. I mean, fortunately, these are extremely rare, and they're very treatable to tumors, and this is rare, but these can be large hemorrhagic lesions. Germinomas have as already discussed, very classic histologic features with these homogeneous sheets or individual cells that are large, round, discohesive, and have these prominent irregular nucleoli. They can also have very pale cytoplasm or even clear appearing cytoplasm. A detection of abundant mitoses in apoptotic cells is very common, and there's also usually a very conspicuous inflammatory cell component, although this can be highly variable. Lymphocytes are almost always present, occasionally even with germinal centers, but it's not uncommon to find non-caseating granulomas and other inflammatory cells as well. Calcifications are common, and this can be detected on MRI as well. And some cases can be quite tricky because there can be parenchymal infiltration of these tumor cells, and they can mimic other tumors such as an infiltrating glioma. So there needs to be a high level of suspicion in some cases for a germline tumor. You know, if it's a young adult, you know, this is always in my differential. There's very characteristic appearance on a squash or smear preparation too, done intraoperatively. So you can make out those large discohesive cells. Mitotic figures are usually readily apparent even on a squash preparation. And then there's these background small lymphocytes that can be quite conspicuous or virtually absent. Here is one example of a germinoma I saw recently where you see these sheets of germinoma cells, but there's really very little lymphocytic inflammation. There's a lot of mitotic figures and apoptotic bodies. And some hemorrhage is really not uncommon to see in these CNS tumors. Here's an interesting example of one that was infiltrating into the adjacent brain parenchyma. And as you probably know, these tumor cells are very fragile, and so it's not uncommon to see them sort of crushed and smeared, like over here on the left side of the image. And so it can be difficult to make out the morphology of these in biopsies. And immunostains can be very helpful in those cases. But here you see that infiltrating population of cells with that clear cell change. And then over here to the right, you know, these tumor cells are infiltrating into brain. And so sampling here is very important because if I saw just the brain here adjacent to the germinoma, this isn't normal. There's reactive gliosis here, but you know, you would potentially go down the wrong route of thinking, you know, am I looking at an astrocytoma or infiltrating glioma? As I mentioned, the inflammatory cell component can be quite brisk and even obscure the germ cell component in many cases. So this is a CD45 stain highlighting the inflammatory cells, and there is a cluster here of cells that are negative that are the tumor cells, and another one up here. This was a squash preparation on a case that I saw recently, and you're seeing in the background here lots of these processes because this tumor was infiltrating into the brain. And so you're seeing axons and various processes here, but this population of cells with very eosinophilic cytoplasm and discohesive, there's mitotic figures. This is a clue that you're looking at a germ cell tumor. Definitely want to, exclude other inflammatory lesions as well. Sometimes there's really just a single cell population and the tumor cells can be quite sparse, and then the small lymphocytes can be quite abundant. As I mentioned, granulomatous inflammation can be quite brisk. And so when you get these very small biopsies, you of course want to think about, ruling out infections like TB, neurosarcoidosis, and hypophysitis. And immunostains can be very helpful in this setting. And as well as serum biomarkers, but OCT4 stain, for example, labels the tumor cells, and even if they're very scant or crushed in these biopsies that have a lot of inflammation. In pure germinomas, there can occasionally be syncytial trophoblastic giant cells, and they can be detected with a beta HCG stain. These may have some prognostic significance in that these may have a slightly worse prognosis than just a pure germinoma without these, but it's always important to correlate with serum beta HCG. Ancillary tests here, IHC it does play a pretty critical role, especially in small biopsies or ones that have crush artifact, because it's very important to exclude other non-germinomatous components. So, on most cases, I do screen using AFP, beta HCG, and CD30, just especially if there's positive serum or CSF markers to suggest that this might be a mixed malignant germ cell tumor. For CNS germ cell tumors at this point, unlike sort of the rest of neuropathology, molecular testing does not really play a significant role at this point in the diagnosis or subtyping. These can show multiple chromosomal imbalances, and a gain of 12p is very common. Somewhat different than non-CNS germ cell tumors is that isochromosome 12p is quite rare, actually. But the immunoprofile is the same as germinomas outside of, or similar lineage outside the CNS. These tumors, fortunately, are very highly radiosensitive, and in some cases, these patients also require chemotherapy. There is a very important role for intraoperative consultation and diagnosis here, because we know that surgical resection really provides no survival advantage and may actually cause disabilities. And so an accurate intraoperative diagnosis of a germinoma can really prevent having to do a larger surgery, and really the patient just needs radiation and chemotherapy. The survival rate is very good for pure germinomas, with over 90% 5-year survival rate. However, these patients really do require long-term follow-up because of that radiation, because they are at increased risk of secondary tumors following radiation. And that's a whole host of different brain tumors can occur after radiation. Moving on to teratomas, similar to outside the CNS, these are just haphazardly arranged tissue components with mesenchymal, epithelial, and neuroectodermal origin. I won't spend too much time on this because it's very similar. I mean, mature have mature elements, immature have immature elements. It's very helpful when you can find mitotic figures and apoptotic bodies in the immature elements, and identify those immature neuroepithelial elements. Very rarely, there can be a malignant component of carcinoma, sarcoma, or other high-grade neuroepithelial tumor with embryonal features like medulloblastoma or tumors formerly called PNETs. And the imaging characteristics are very similar to outside the CNS. They're complex, heterogeneous cell cystic masses, and they can be quite large. And this image here on the right, you can see that there's a small rim of normal or compressed but non-neoplastic cerebellum here at the edge of the tumor, and then a very large tumor basically taking up the whole cerebellar hemisphere in this young infant. This ended up being an immature teratoma, and these when these occur in neonates have a unfortunately, very poor prognosis. As I'm sure you all know, mature teratomas have these very mature elements. In this picture, we can see glandular, cartilaginous elements and cysts that are lined by, enteric or gastric or respiratory type mucosa. Immature teratomas frequently have these undifferentiated components that form neural tube-like formations, which is seen here on the left. These, as I mentioned, can occur in very young infants. And we've had some cases here that are extremely difficult to differentiate from embryonal tumors with multi-layered rosettes. They're both large tumors. They both affect infants. They can have these multi-layered structures that can have a lumen, but can be more Homer-Wright rosette-like, where there isn't a central lumen, similar to the ETMRs. So molecular testing, it can be very helpful in that these should have the C19 MC alteration in ETMR, whereas the germ cell tumors do not. Unfortunately, both have a pretty poor prognosis, however. For mature teratomas, however, the prognosis is great. Gross total resection is pretty much all those patients need. However, careful examination for immature or malignant germ cell components is needed, because those patients will require multimodal therapy. And the prognosis really depends on the presence of the embryonal yolk sac or choriocarcinoma or other malignant germ cell, malignant tumors that arise in a teratoma. And then the third category, which we're always screening for, is the mixed malignant germ cell tumor. These have a median age of about 10 years in the CNS. The most common combination is teratoma with germinoma. And then mixed germ cell tumors are more common than any of the pure germ cell tumors except germinoma. So we see these more than any pure, for example, choriocarcinoma or yolk sac tumor, for example. Frequently, we're getting very limited biopsies, and so it is not unheard of to miss the non-germinomatous components in these mixed germ cell tumors. And so its correlation with either serum or CSF, alpha-fetoprotein and beta-HCG levels is critical here, to make sure that if it is a mixed germ cell tumor, it gets diagnosed. Unfortunately, these mixed tumors are less radiosensitive than germinomas, and the pure non-germinomatous germ cell tumors are really the most aggressive of the bunch, and are the most concerning and often metastasize. In any CNS germ cell tumor, it's always wise to consider if the tumor could represent a metastasis from the testis, lung, or mediastinum, and so these patients do require comprehensive staging. So similar to what Dr. Chen had just shown, embryonal carcinoma, has these large anaplastic cells with epithelial features, frequent high proliferation index, and cytokeratin and CD30 positive. Usually not too hard to recognize in the mixed germ cell tumors. Yolk sac tumors, I find significantly harder to recognize in these mixed germ cell tumors. They often have these primitive epithelial cells, but instead of those thick cords that you see in embryonal carcinoma, they're much thinner in yolk sac tumor. They can have multiple different growth patterns, as mentioned before. So they can have loose, solid glandular, microcystic. They like to hide, in my experience, and immunostains are very helpful to identify them if possible. And here's another picture of those beautiful Schiller-Duval bodies that can also occur in the CNS yolk sac tumors. And here again is just a different view of the spectrum of morphologies you can see with yolk sac tumors. You can see them grow in trabeculae or sinusoidal growth patterns. AFP expression can be patchy, and glypican-3 in my hands has sort of a variable utility, but of course, correlation with serum or CSF alpha-fetoprotein levels is very important here for both diagnosis and monitoring disease response to treatment. Here's an example of that AFP staining that looks quite patchy. And then finally, choriocarcinoma. This is a combination of usually two cell types, it's the cytotrophoblasts, and then these large multinucleated syncytiotrophoblastic giant cells that in some examples can be seen lining large blood-filled channels. And I will show you an image of that in a bit. These are frequently associated with hemorrhage and necrosis, and of course, express beta-HCG. I saw an interesting autopsy case several years ago where a young adult male, apologies, actually presented with a brain hemorrhage, and at autopsy and of uncertain etiology. And it wasn't clear at first that there was an aneurysm or, you know, stroke or what had happened here. There was no definite mass lesion, but in examining some of just that hemorrhage from that had filled, you know, made this big hematoma in the parenchyma of the brain, there were metastatic choriocarcinoma cells there. So essentially a large hemorrhagic lesion was the cause of death due to metastatic choriocarcinoma in this patient. Here's some staining examples of those syncytial trophoblasts with multiple nuclei. And these mixed malignant germ cell tumors are less radiosensitive than germinoma, as mentioned, and have a much worse overall survival of, you know, about 30 to 50% 5-year survival. And if metastatic, it's even worse, unfortunately. I apologize, I might be missing some messages here. Oh, there was a question about choriocarcinoma. I think there are only very, very rare examples of a primary pure choriocarcinoma in the brain. Extraordinarily rare. So if you see pure choriocarcinoma in the brain, it's most likely a metastasis, yes. And so I wanted to just end with this case that we had here at our institution, that sort of an interesting clinical presentation. This is a 9-year-old boy who presented with evidence of precocious puberty. So actually his parents brought him into the clinic because they noticed that his muscles were extremely well developed for a 9-year-old boy, and said that he was referring to himself as the Hulk. So he underwent testing and was found to have an elevated beta HCG and testosterone level, most likely due to that beta HCG stimulation of Sertoli cells. And then later had brain imaging that revealed this pineal mass. This is a representative low power image of this tumor. There were, you know, enlarged cystic spaces, and then sort of areas that are slightly crushed here that are more hypercellular and concerning for sort of a mixed lineage tumor here. Higher power, you can see some of these, again, mature elements, and then some stroma. But then in other areas, you can see these nests of very ugly malignant looking cells with mitotic figures that are very concerning for embryonal carcinoma. There's a higher power, again, of highly mitotic nodules of these tumor cells. In other areas, there were cells that there were these syncytial trophoblasts that labeled with beta HCG, and as I mentioned, they can sometimes line these channels, as in this example. CD30 highlighted those little nests of embryonal tumor scattered throughout the tumor. And alpha-fetoprotein, although there were these areas that had these sort of thin-walled, you know, cystic areas that, you know, could potentially raise suspicion for a yolk sac tumor, but the tumor was completely negative for alpha-fetoprotein. So the diagnosis of a mixed malignant germ cell tumor with components of embryonal carcinoma, choriocarcinoma, and mature teratoma was made. The majority of the tumor was the mature teratoma. There was no definite yolk sac. Unfortunately, CSF was negative, so we don't think that there's actually a yolk sac component in this tumor. He received chemotherapy on a study protocol and proton radiotherapy, and then subsequently developed growing teratoma syndrome, which I'll talk about just briefly here at the end. But we've seen this quite commonly in many of our patients here. Because of that growing teratoma syndrome on therapy, he underwent a gross total resection, which was very successful. And he's now over a year out with no tumor recurrence on MRI or serum markers. And fortunately, his testosterone levels have now decreased and are within normal limits. And he is still very tall for age, but his muscle bulk has sort of regressed back to what it would be expected for an adolescent male who's around 10 years old. So finally, just wanted to end with a couple slides about growing teratoma syndrome, because I think this is an important thing to recognize, and this occurs both in the brain and outside the brain with teratomas. And this just refers to this paradoxical growth of the teratoma that can be observed either during or pretty close after systemic chemotherapy. And this occurs in the context of tumor biomarkers actually normalizing. So you can see here, this is alpha fetoprotein levels are decreasing and quite low and within normal range, but the teratoma here has grown from 4 centimeters to almost 6 centimeters in that time. And so that of course can cause symptoms, it can cause obstruction. And so gross total resection in these cases is very helpful, and those patients tend to do well after they have surgery. It can occur in anywhere from 5 to 10% of cases. And an evaluation of the tumors after resection, it appears that the malignant components are very chemotherapy and radiation sensitive and sort of disappear and melt away. However, the teratoma component is not and continues to grow and potentially is even stimulated by the therapy. So the awareness of this is important because we want to prevent unnecessary further chemotherapy in these patients and recognize that this can be seen and is expected, and that in the context of normalizing serum biomarkers is not evidence that the therapy is not working. It just need to give it time, and the gross total resection is important indicator of eventual prognosis. So that's all I had for CNS germ cell tumors, and I'm happy to try to answer any questions. Thanks so much.
Thank you very much, Dr. Thomas, for the wonderful presentation. You really had it going. It was really wonderful. We are really grateful for your participation. As finishing touches, maybe if participants have any questions for either Dr. Thomas or Dr. Sonja, you are much welcomed. I think we had a number of questions in the chat box. Dr. Sonja had been replying to some of them.
Yeah, I think I was just replying for there was a question of whether Diana was calling germinoma akin to seminoma, but they all the same cell type. They're just different names for the different locations. I didn't make it so. That's just how it is. So germinoma in the CNS, is germinoma in the ovary, and seminoma in the testis or any other extragonadal site.
Yes, thank you for clarifying that.
I will just say something for growing teratoma syndrome. I think the one case that I vaguely recall having of that was a patient who had gliomatosis peritonei. And I think, this is another thing that's really, really hard to treat. Sometimes it doesn't respond to chemotherapy, obviously. And so they kept going back to, get a little, they ended up doing multiple omentectomies for this gliomatosis peritonei, but it continued to grow despite her treatment. That's the only case that I can remember here so far.